Let's go on and do this. Okay. Ophthalmology is the way that word is pronounced. Let me say it again. The OPH makes an OF sound. Ophthalmology is how you would pronounce that. OPHTH. Most people spell this word incorrectly because they usually forget this first H right there. And they sometimes want to pronounce this ophthalmology, OPH. If you make sure you say it that way, it'll help you to remember that there is two H's in this word, ophthalmology. Okay, ophthalmo refers to the eye. Opto and opti also refer to the eye. Okay, and then logy is the study of. Some other word parts we'll be talking about today, word parts like blepharo, which means the eyelids. So there's your first read for you. The medical term that refers to the eyelids is pronounced blepharo. For example, if you have the condition of blepharoptosis, that's drooping eyelids. We get that as we get old. So it can be so bad that it actually starts to affect your vision a little bit, that your eyes are just drooping down. You can't see because I'm glasses on. That your eyes are just drooping down, okay, because you're just getting old. So that's how one case where that word is used, blepharoptosis or blepharitis, inflammation or infection of the eyelids. Remember we said yesterday, itis is one of our most common suffixes. So blepharoptosis or blepharitis, both referring to the eyelids. All right, now there are two doctors that work in this area, starting with the ophthalmologist. This person is your MD. This is your medical doctor. They went to the same school, medical school, as every other medical doctor out there. And when they chose their specialty, they chose the eyes. So this is the doctor that treats diseases of the eyes, like glaucoma, conjunctivitis, any type of disease that happens in or around the eye. You're going to see the MD, the ophthalmologist. Now, the optometrist, this is your eyeglass doctor. Now, they still have a doctorate degree, but their doctorate is in optometry. So they have a DO versus an MD. DO is Doctor of Optometry versus the MD. So it's still a doctorate degree, but it's in a different area. So these are the guys that go to optometry school, and they'll be in there for something like 6 to 8 years working on their doctorate degree. So that's your eyeglass doctor. That's the person you go and see if you have nearsighted, farsighted, you've got a astigmatism, you go and see your eyeglass doctor. So, and it's really simple in a clinic to determine if a person is having difficulty in their vision, they're seeing blurred vision or whatever. It's real easy in a clinic to determine whether they need eyeglasses or eye surgery. And that is a test we'll be talking about today. It's called a pinhole test. And it takes about 2 minutes to do. And based on that test, we can decide whether our patient needs to go to an ophthalmologist for eye surgery or an optometrist for eyeglasses. In other words, do they have a cataracts or do they have an astigmatism? Having astigmatism, we send them to the eyeglass doctor. If they have cataracts, we send them to the ophthalmologist for eye surgery. And that's real easy to do in a clinic to figure out which one to send them to. So that's ophthalmology, the study of the eyes and vision. The purpose of the eyes is to pick up light rays, transmit those rays to the brain. Now, I haven't asked this question in this way yet, so let's do it now. How many people, or not how many people, but what do you see with? What do we see with?
With pupil.
Our what?
Pupil.
Pupil, okay. Anybody else? What do we see with? Okay, we see with our brain. Okay. Our eyes pick up the light rays and transmit those to the brain. But then those electrical signals that reach our brain are then compiled into an image. So we don't see anything until our brain assesses the electrical impulses that are coming in. See, we don't get light rays into the brain. And we should change this, transmits or picks up light rays and then transmits electrical signals to the brain. The brain then assembles that into an image, and then you can search your brain to see if you've seen that thing before. If not, you can create a memory cell for it and record it. But we see with our brain. We hear with our brain, taste, touch, smell, all of our senses, we do those with the brain. Our nose picks up scents that are then converted to electrical signals, and our brain then makes sense out of what we just smelled. So we don't smell with our nose, we smell with our brain. We taste with our brain, and we see with our brain. And that's why if somebody can see a thing that's not really there, their eyes are not picking up any light rays telling them that there's a person standing in the corner over there. But if their brain tells them that there is a person over there, then it's just as real as if they were picking that up with their eyes. So we see with our brain. So the purpose of the eyes is to pick up light rays from the around us and then convert those to electrical signals. And then in the brain, a picture is assembled for us. Okay, so we're going to start our look at the eyes with structures that we collectively call the adnexa. Now, this is the same picture from your textbook. I don't remember what page it's on if you want to follow through like that. Adnexa. These are structures that are associated with vision, but they have no, or a structure associated with the eyes, but they have no role in vision. In other words, the picking up the light rays and transmitting those to the brain, these structures have nothing to do with that, but they are associated with the eyes. And you can see the types of things we're going to be talking about, starting with your eye socket. The eye socket is the depression in the skull where the eyeballs sit. Welcome, Chris. Good to see you. The socket in your skull bone where the eyeballs actually sit back in their recess just a little bit. And they help to protect the eyes. A blow to the head or something. You may have seen some people out there in the world or in TV or whatever where they have a scar that goes across their forehead, stops at the eyebrow, and then picks up on their cheek. Something came across, boom, and because the eye was recessed, it saved that eye and just gave them the scar that went across the tissue right there. So when our eyes recessed, that helps to protect them some. Also giving a little bit of protection from the outside, but not much. Back in the day, thousands of years ago, our eye sockets on the outside probably came way out farther than they do today, probably as far as this. But when they came out that far, we had no peripheral vision. We couldn't see what was going on our left side or right side. As a result, over generations, it recessed backwards so that we could actually see what's over there. The problem with that now is that this part of the eye is not protected anymore. So coming from the side, you actually could get and damage a person's eye coming from the side, not from the front, but from the side. So our eye sockets help protect the eyes just a little bit, not a whole lot, but they do still give some protection. The next structure are the eyelids. We already said that blepharo means eyelids. Our eyelids are designed to protect the eyes as well. When something is coming at the eye, that's why we tend to close. But we also help to keep the eyeball moist by blinking. And then again, squinting to keep dust and that type of stuff out of the eye, but then closing the eyes to sleep or when we're in water or something like that. So the eyelids help to protect the eyes as well. And again, that word for eyelid is blepharo. Now, the underside of the eyelid has a pink membrane that you may have seen before. Back when you were kids, if you ever did the, flip your eyelids inside out thing, like, oh, look at me, I look like a zombie or whatever. And your mama might have told you that if you keep doing that, your eyes gonna get stuck like that. And the truth is they won't. But exposing the conjunctiva to the air like that could cause it to become infected. And what do we call it when the conjunctiva becomes infected? We call it conjunctivitis. Remember, itis, that most common suffix, conjunctivitis. You have an infection of the underside of your eyelid, that pink membrane under there. If you lift it up right now, you could see it. And that's why we shouldn't be exposing the conjunctiva to the air like that. It could become infected. Now, conjunctivitis is highly contagious, especially for the first 72 hours. And those are the two things that should not be tolerated at daycares or anything like that. Remember that if your kid goes to school with red eyes or you're taking the daycare with red eyes, they're going to tell you to take the kid home because of how contagious conjunctivitis actually is. Every kid in that daycare would probably leave with conjunctivitis that day. And then the other thing that they shouldn't tolerate at daycares is biting. Okay. So, and they both having to do with infection control. A human bite is is the nastiest bite you can get. Okay. I would rather have a dog bite than have a human bite. That's how much bacteria we have in our mouths and things. So anyway, the underside of the eyelid is called the conjunctiva. And mentioning daycare, something y'all might want to think about is that, there are a lot of people or a few people who are unemployed right now. And if you're looking for an option for your kid rather than go to school, maybe a babysitter could work for you. And the kid could sit at home. You can pay somebody a little bit of money to watch them for you. Remember, they're not licensed daycare, so make sure it's somebody that you trust, a sister, a family member, something like that, that you trust that you can leave your kid with. And maybe you can help them. They can help you. Pay a little bit of money, watch my kid while they go to school today. So think about that as well, because I am really just against sending kids to school right now. All right, so anyway, the eyelids are known as blepharo, and the underside of the eyelid is called the conjunctiva, that pink membrane under there. Now, imagine what it would be like to have no eyelids. What would that be like, y'all? There's Esther. What would it be like to have no eyelids, you think? Would that suck just a little bit? How would you sleep at night? Well, people automatically say, well, you'd cover your eyes with something. Well, if you had no eyelids, the thing that you covered your eyes with would actually be touching your eyeballs. You ever had a hair in your eye? How annoying is that? So imagine a cloth covering your eyeballs while you're touching your eyeballs while you're trying to sleep at night. How would you take a shower? What would you do on a windy day if you had no eyelids? So something simple, and imagine living without it. And I know of at least one case where a kid was born without eyelids. And what they did, the good news is that he was a little boy, and they were able to use the foreskin from his circumcision to create eyelids. Isn't that cool? Except when they got done, he was cockeyed. Boom, boom. Get it? I forget y'all, man. It was funny when I heard it.
That's funny.
It was funny when I heard it. No, I don't know of anybody who was born without eyelids. That was a joke. But, I guess it's early for y'all. Anyway, thank y'all for just like blowing my joke, man. Anyway, so that is the eyelids. The next part of the conjunctiva will be your Structure associated, eye socket, eyelids, blepharospasm. Another one of your test items is this word right here, pronounced hordeolum. Hordeolum. It's the medical term for stye. A stye is an infection in the follicle of the eyelash. So, you know, you've got your eyelid with the eyelashes coming out right at the edge. You get an infection in one of those, a bump, red bumps appears right there. That's a hordeolum, a stye. It's an infected eyelash follicle. Why do I put that one on your test? Is it real important? No. But why do I put it on your test? Because it's one of the questions that I missed on one of my tests back when I was just learning this stuff. I couldn't remember what that thing was. What's the medical term for stye? I'm going down. I just couldn't remember. Got there late. Ah, man, it's hordeolum. Damn, why couldn't I remember that? And that is a little bit of lesson for you about school itself. Always review the answers that you miss on a question. And after you finish the quizzes, you can go back and look at all the ones that you actually missed. Okay? Always review the questions that you missed on the test, because those are the ones that you're going to remember. How many tests y'all think I've taken in my career? Hundreds and hundreds of tests. Do I remember every question on every test? No. Do I remember every question I ever missed? Yes. Remember when I'm talking about hordeolum, that was 1982, y'all. So that was 37 years ago. So you do remember the questions that you missed. Go back and review those. Those will be the ones that you actually remember later on. So a hordeolum is the medical term for stye. I kind of keep that on there to show again that not everybody knows everything. Okay, the next section we want to talk about are these pink looking structures on here. And again, this is the same image that's in your textbook. We're starting up here with your lacrimal gland right there. And then your lacrimal ducts right here. Over here is your nasolacrimal duct. Naso meaning nose. And how does this system work together? Let's go ahead and let's go on and get the nose in right here so you can just kind of see it. All right. So how does this work? Okay. The lacrimal gland produces tears that come out onto the eyeball, and they keep the eyeball moist, and they also keep down the growth of bacteria. Tears contain lysozyme. This stuff breaks down bacteria. So it keeps your tears, so it keeps your eyeballs from becoming infected all the time. So the tears are produced in the lacrimal gland. They come out through the lacrimal ducts, out onto your eyeball. They wash across, keep the eyeball moist, keep down the growth of bacteria, and then they are absorbed in the nasolacrimal duct, down into your nose, and absorbed in the mucous membrane down there. So excess tears will flow into your nose. And that's why when you cry, your nose runs. We don't know why we produce more tears in response to emotion. We just know that we do. There's no scientific reason for that. But when we become emotional, the lacrimal glands overproduce, or they increase their production, and we start making too many tears. And then they run out over your eyes and down your face, and you're crying. You're still going to be absorbing a lot of tears into the nose. So that's why your nose runs when you cry. You put so much down here that the mucous membrane can't absorb them all. And as a result, they start running out your nose too. So that stuff coming out your nose when you cry, that's not snot, it's tears. So go ahead and stick your tongue out and catch them as they run down your face. Okay? Because it's just tears, it's not snot. All right, so that's our lacrimal apparatus, all the structures together, the lacrimal gland, lacrimal ducts, and the nasolacrimal duct, draining the tears down into the nose. Now, some people out there in the world can either damage this gland in many cases, and as a result, it starts producing too many tears. And you've always got tears running out your eyes. Your nose is constantly running. So we call that no real technical term for it. It's just a weepy eye. It just runs all the time. So they get, handkerchiefs, that type of stuff, and have to blot the cheek constantly. Again, the nose is running constantly. And do y'all remember when you had a cold with your nose running all the time, you're wiping your nose all the time, it gets all irritated right there? That irritation is happening here and all the way up on their cheek from constantly wiping their face. Now, the good news is that they have little tiny plugs that they can put into these nasolacrimal ducts and slow down their production of tears. They can do all of them or just most of them and leave a couple open, however they want to do it. But imagine how tiny these plugs must be, because these tubes are just slightly bigger than a hair. And they can go in there surgically and insert plugs into them so that you don't produce so many tears throughout the day. And they're not running over your face and they're not running out your nose. Okay, now that would be a lacrimal gland that's producing too many. Sometimes you also will have damage to this bad boy and it stops producing tears altogether. And now they're not getting any tears onto their eyeball. As a result, their eyeball is going to get dry and infected. So we give them an artificial tear. The most common one is called restasis. And you can't use like Visine or anything like that because those don't contain lysozyme. And you'll have infected eyes all the time. But restasis has the lysozyme and also keeps the eyeball from becoming dried out. And whenever they start getting that scratchy sensation in the eye, like when you're sleepy, I feel like the Sandman came. Whenever they start getting that sensation, they just apply a couple of eye drops. So having no tears being produced is probably a little bit better than having too many tears. It's easier to handle. We just give you the restasis. The other case, you have to go in and put those little plugs in there. And remember, if your insurance isn't covering this, then just carry a handkerchief with you and have the irritation on your face right there. So that's our lacrimal apparatus with the lacrimal glands, lacrimal ducts, and then the nasolacrimal duct, washing tears down into our nose for us where they can be drained or absorbed. All right. And there's the red for you. The lacrimal apparatus is responsible for producing and draining tears. And all those words we've used: lacrimal gland, lacrimal ducts, lacrimal sac over there, the nasolacrimal duct, and then the lysozyme that breaks down bacteria.
Sir, I know you. Sorry, this is Renisha. I was saying I wanted to let you know I was here,
I
but
got
you got the note. Okay.
da da da. I got you when I saw you when you came into class, so I got you.
Okay. Thank you.
The people who I still have marked absent are Jordan Carter, Davion Henley. Oh, there you are. Never mind. Good time to do this, man. Da da da. Did Jasmine show up? Jasmine Jackson, Jasmine, you here? Jasmine, I thought I saw you, guess not. Vanessa Pargas, still not here. And Alma Espinosa, still not here. I got Esther. Alma Espinosa, you here? Okay. So those ones that still have a marked absent. I'll get them. Yeah, I got to go on and do the email right now. So thank you. So I do need to go on and do this email. I know where Jordan is. Never mind. I mean, I need to put her in there, but I do know where she is. I forgot about that. So I know where Jordan is. Not that Jasmine's not here yet. Still. All right. So Jordan Carter, Jasmine Jackson, Vanessa Pargas, Alma Segovia. And then I know where Latasha Reed is. I'll put her in anyway. Okay. So Jasmine, Vanessa, Alma, anywhere. All right. Sent. Oh, look, my order has shipped. Cool. All right. Yay. Ordered some stuff on Amazon last night, so I'm kind of excited about getting my package because I want my stuff. Okay, so that is the lacrimal apparatus and what it does. The next thing associated with our next part of the adnexa we call our eyelashes. The medical term for eyelashes are any hairs that you see, for example, nasal hairs, eyelashes, hairs in the nose. Those are called cilia, tiny hairs that are used to filter, and the eyelashes are example of cilia. And we mentioned one of the main problems with eyelashes is the stye, the hordeolum, an infected eyelash. Now, if you, okay, so anyway, those are eyelashes, cilia. And you might hear that term later on in your classes, cilia, always meaning tiny hairs, nasal hairs, hairs of the ears, hairs in your respiratory tract, hairs in your digestive tract, and your eyelashes. They're all cilia. So eyelashes are an example of cilia. Probably only the issue that happens is the infected eyelash or when you get one of these bad boys in your eyes. And in healthcare, we don't go poking in people's eyes. If there's something in your eye, we're going to wash it out with fluid. So medical assistants will be more involved in that than PCTs. Remember, you hardly ever go in the hospital for an eye problem or an ear problem. Those are usually handled in the clinics. But medical assistants will get into doing eye washes, washing stuff out of people's eyes. Don't do what my mother used to do. You get something in your eye. I just finally stopped telling her, man. I went to my mom, there's something in my eye. So I don't know if y'all did this, but you grab the little Kleenex and you fold it down to a point, and then hold still, boy, trying to swipe the thing out your eye, just stabbing you in the eye with the corner of this Kleenex the whole freaking time, man. How annoying is that shit? So anyway, we don't go poking in people's eyes. We will wash out whatever's in there. And I advise you to do that at home as well. Just wash your eyes out rather than trying to. You ever have mama try to blow it out? You know, it's like, come on, man, really? You're blowing in my eye, dude. So anyway, that is boom, a no-no for us. We're going to wash the eyes out. If somebody gets a chemical in their eye, like gasoline, for example, how long do you think you should irrigate a person's eye if they get like gasoline in the eye?
Like 30 minutes.
30 minutes, okay. Anybody else?
10 minutes. 15 minutes.
Just you call them all out, Chris. 3 minutes, 2 minutes, you'll hit it eventually. 20 to 30 minutes or so. But in the emergency room, we had a saying, irrigate till the doctor walks in. I'm sorry, you're irrigating the eyes. It's been 15 minutes. Keep going. Just keep going until the doctor walks in the room to examine the patient. So there was never really a set time for us, but textbooks say between 20 and 30 minutes. All right, so the next section of the adnexa we want to talk about are the extraocular muscles. And again, this is the same image from your textbook. These muscles move the eyeballs and let you look around in all different directions. And you see how they are arranged on the eye. The superior rectus, first of all, they're called the rectus muscles. One of them is superior. It pulls the eyeball up so you can look at the ceiling. The medial rectus. Get used to the terms medial and lateral. We'll be testing on those next module. Medial means towards the nose or towards the middle. Lateral means towards the side. If there are any football fans in here, you know, every now and then the quarterback tosses the ball out to the side, and they call that lateral. He lateraled the ball out there. Okay. So lateral will always be to the outside, medial towards the middle. So with both our eyeballs, medial for this eye would be this side. Medial for this eye would be that side, moving towards the nose. Lateral's over here, lateral's over there, moving towards the side. So the medial rectus and the lateral rectus. So this is obviously the right eye. On this eyeball on the left side, you have superior, medial, and lateral. Okay. So medial is always towards the nose or towards the middle. And then the inferior rectus, pulling the eyeball down. So this one helps you look over towards your nose. This one to look out towards the side, to look down, and then to look up, pulling on the eyeball in those directions. We also have our oblique muscles coming up right here. Superior oblique, it pulls around below this muscle through an area called a trochanter and back like this. The inferior oblique pulls down the same way and attaches into the bone right there. And these two muscles help you to roll your eyeball like this, like that. So the next time your teenage daughter, or not even teenage anymore, your 9, 10-year-old daughter is rolling their eyes at you, you can confuse them a little bit. And you can say, don't be using those obliques with me. Yeah, don't be using those obliques. You're rolling your eyes. And girls do it way more often than boys. And that's why I say you're little teenage girls. I don't know what y'all think y'all doing. Rolling your little eyes at people. Okay. I don't know what made me think about this, but one day my wife was getting on my daughter about something. And I guess she was about 12 or 13 years old. And my wife just, hey, let me tell you something. And da, 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 da. And now you go into your room. Chris is walking away. So when she's walking away, she goes, bitch. I was like, did she just, oh no, you bring your little ass here. Let me, da, 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 da. Well, I had to go outside on that one, y'all, because I was laughing so hard. Like, bitch. So anyway, y'all, it's harder raising girls and boys, man. I'm just telling you, I've got 2 daughters and a son. My son, I just kind of slap him upside his head. But my daughters, you can't do that. So it's hard raising daughters, man. You damn girls get on my nerves. So anyway, those are your extraocular muscles. Superior, inferior, medial, and lateral rectus, and then the superior and inferior obliques, helping us to move our eyes in all different directions. Now, if these muscles aren't working properly, you're probably going to end up with a strabismus, abnormal deviation of one eye. Now, strabismus can be, I don't know, they're hard to look at people who have these sometimes. It's like this, where one eye is deviated and the other eye is straight, one is moving off in the other direction. And there are 2 versions of this. You have a cross eye or a wall eye, upper like that or lower like this. Did this lady actually do this, or were these, I think these were touched up, but anyway, the 2 most common are going to be the cross eye, where one eye is turned towards the nose, or the wall eye, where one eye is turned towards the side, cross eye or wall-eyed. And it's going to affect a couple of things. Number one, when our eyes, oh, there's our fibrillation from yesterday. Okay. If you're looking at the top of the person's head, 2 eyeballs, and they're looking this direction, our eyeballs actually pick up light rays like this. And you have an area that crosses, and your brain then takes all of this and puts it together as one image for you. That's why you don't see double vision right there in the center, even though your eyeballs do cross. Now, when you have a strabismus, so in other words, didn't mention that, when your eyes are angled correctly, this is your center right here. Okay. But when you have a strabismus, a cross-eyed, for example, you see what happens to their field of vision? And their center moves over here. So this person would be looking right at you, but their head would be turned slightly. And you're wondering, are you looking at me? Yeah, they're looking right at you. And you're right in the center. But they've got to turn their head this way so that their center lines up with center right here. So this right here has been thrown off. And they're going to move their head until this appears over here. So they're going to turn their head to the side slightly. Even though they're looking right at you, you'll be actually looking more towards their ear. So it's kind of weird when talking to these folks because it looks like they're not looking at you because neither one of these eyeballs is looking at you. They turn their heads so that you appear in the center of both of them rather than one of them looking at you. And that makes it look like they're not looking at you. And that makes it difficult for you to go, okay, so how do I look at this person then? Which eye do I look at? Don't look at either one. Look at their nose. If it distracts you. Because they will, and it'll look like neither one of those eyes is looking at you. One's over this way, one's over that way, you're in the middle. He's like, what are you looking at? They're looking right at you. It's just that their center is the mergence of the two eyes, not one's over here, one's over there. They're using the center to see you. So it's kind of hard to look at them when they're talking to you because it looks like they're not looking at you when actually they're looking right at you. All right, so that is a strabismus. The other form is that you have this, you have that, and this eye is looking straight like it should, but this one is way the hell over here. This is difficult for them. They have no mergence of the two eyeballs. There's no center. So what the brain does is discount the input from that eye. And they may turn their head completely where this eye is way over and they're looking at you with just one eye. They have no center to merge in their brain because their eyeballs don't overlap. They don't converge. And their center is not in either field of vision. So they discount that and then turn their head like this to get a center. Because the other eyeball isn't even close to giving them a center. Right. So anyway, that is what the hell happened to my picture? Anyway.
That repair? Is
What?
that repair?
It all depends on the eye muscles. Are they weak or are they permanently damaged? Remember down here in this person's head, there's a, oh, damn it. I'm tired of starting this stupid pen. In this area over here, there's a muscle that pulls the eye that way, a muscle that pulls the eye this way. Over here is the same thing. Now, what's happening in this person, this eye isn't maintaining, or this muscle isn't maintaining tension for them. Therefore, this one pulls the eyeball completely to that side. When we look at our eye muscles, they apply what is constant tension on the eyeball. So they pull all the time. And when you want to turn your eye to one side, attracted to that side, this muscle relaxes and allows the stronger muscle to pull it to that direction. When you want to go the other way, this muscle relaxes and the tension from this one pulls it the other direction. So if we didn't have constant tension on these muscles all the time, the eye would twitch. So that constant tension keeps the eyeball steady. And when you want to move it, you relax this one, and that one pulls it to the other side. Okay. So what's happening here is that this muscle is not working at all. It's not applying tension. So this one pulls it completely to the outside. So that muscle over there is not giving any tension at all. Therefore, this one pulls it completely to the other side. So if this muscle is not working at all, then no, you can't repair this. If it's just weak, in other words, this muscle is stronger, this muscle is weaker, the normal tension that's always on this muscle will pull the eye to the outside. In that case, you just need to strengthen this muscle right here so that they both are the same strength and can keep the eyeball straight. That's kind of easy to do with a exercise. And the exercise is whichever way the eye is drifting, you need to strengthen the muscle on the other side. So if their eye is drifting to the outside, you need to strengthen the inside muscle. And you do that by having them focus on something in the direction of the muscle that needs to be strengthened. So if their muscle is drifting, or if their eye is drifting towards the inside, towards their nose, you want to strengthen the muscle out here. And you do that by putting something out here and having them focus on it. I don't know if y'all can see my eyes or not. Put something out here and have them focus on that. Applying tension to the muscle on this side, thereby strengthening it. Start out further, and as you bring it in, they're bringing the eyeball farther and farther in that direction. Strengthen that muscle over here. And you do that exercise as often as you can. Now understand that it's going to cause them a little bit of a headache. Just like you work any muscle, that muscle starts to hurt. You're working this muscle out here, that muscle's going to get tired, it's going to start to hurt a little bit. You'll get a little bit of a headache. So you do the exercise as often as they can tolerate it, 2 or 3 times a day if you can. Okay? And eventually this muscle out here gets strengthened and their strabismus won't be near as noticeable. Okay? You might notice if you look right at them and stare at them, but in casual conversation or just in passing, you'll never notice they have a lazy eye, an eye that drifts when they're not focusing on something. So as long as this person is looking right at the thing, it's no problem. They're applying tension and the eyeball will stay there. But when they stop focusing, it starts to drift to the lazy side or to the strong side. Strengthen the other side. If they're drifting this way, put the toy or whatever at their nose, bring it out, and then bring it in slowly, telling them to keep their eye on it the whole time. And also, you might want to patch the eye that's not a problem for them, and work just on the lazy eye. Both of my daughters were born with lazy eyes, and it was real easy to get it to the point where you're looking at them, you'll hardly notice today. So that's it. Go ahead. What?
I said mine were like that. I had to have corrective eye surgery.
Okay. Yeah, they can go in some cases and shorten the muscle. That is, the issue. For example, you got this going on, the eyeball being pulled completely in that direction. It might be a matter of shortening this muscle over here. So it all depends on what's causing it. If they go in and take some of that out, pull that together now, the eyeball will be pulled straight and make both muscles the same length. Okay? So it may be a matter of going in and shortening the muscle. But if it's a muscle that's not working properly, not a whole lot they can do about that except to cut the muscle completely and permanently fix the eye in that position so that at least it's straight. So you won't be going around your whole life with cross eyes. So if that muscle is permanently damaged, they'll cut this one, straighten the eyeball out, and it'll be permanently fixed straight like that. Okay. And even in those people, you'll see it because when this eye moves around, that one stays straight. But at least when they're looking at you and taking pictures and that type of stuff, they're not like way over here with their eyeball. All right, so whether they can fix it surgically or not depends on the condition of the muscle. Is it working at all? Is it totally inactive? So that's a strabismus, abnormal deviation of one eye. It can be left and right, up or down, depending on the muscles. All right, and you see that in red. All right, so those are the adnexa. The eye sockets, the eyelids, eyelashes, the lacrimal apparatus are all parts of and the extraocular muscles are all part of the adnexa. Now, as for the eyeball itself, you have the images in here and the words. So I want to get onto here and let's do my Michelangelo. Y'all ready? Remember what Michelangelo did? He made a perfect circle, freehand. All right, let's see. Let's do our Michelangelo right here. And let's do it in blue. All right, here we go. Ready? Oh, man. Anyway, I do it better on the whiteboard. Let's try it again. All right, start right here. Damn it. Why is this so important? Because your vision is based on the shape of your eyeball. If your eyeball is not round like it should be, your vision is going to be affected. So here's what I'm going to do for y'all. Check this out. All right, now. Oh, man, it's not doing it. When you do a circle, it's supposed to snap it to a real circle. But anyway, and that's the ink to shape. But anyway, it didn't work, so forget it. All right, so now, what do I mean by the shape of your eyeball? Is anybody nearsighted? 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 Yeah, y'all four-eyed. Look at y'all. I see all them glasses out there. Don't be raised. Don't be like sitting there. Y'all four-eyed. All right, so if you're nearsighted.
I'm nearsighted and I have astigmatism.
There's your eyeball. Anybody farsighted?
I honestly don't know. I just know I don't have to wear glasses and I have good vision.
You see the difference? Nearsighted and farsighted, it's caused by the shape of the eyeball. Their eyeballs are not round. And that's why up until LASIK surgery, we really couldn't do anything about nearsighted and farsighted except give you glasses. Because it's caused by the shape of your eyeball. Your eyeball is oval this way or oval that way. It's not round like it should be. All right, so that's why I play around with that circle a little bit. But anyway, I'm not doing good circles today. Whatever. All right, so your eyeball is round like that, and it's covered with a coating that is white in color. And this is a test question. The white part of the eyeball is called your sclera. Sclera. And it's in the PowerPoint too. The sclera is the white part of the eye. And this image, you see it really well. The sclera is this part out here. The white part of the eyeball. Now you also see that as the sclera comes up to the front, it actually then bubbles out. Nah, that's a bad color. Let's get a better color. Actually bubbles out like this into a dome-shaped curve. That dome is called the cornea. So the sclera, as it comes around front, turns into the cornea, and the cornea is nice and clear, so you can see through it. So the pinkish part, that's solid white. The sclera is a dome-shaped, that gets clear so that you can see through it. If you're actually looking at this from the side, it would be like this. And then continuing the sclera. So the sclera here and here, the cornea right there, where it domes out. And that's clear. You can see right through it. Now, some people's corneas won't be shaped right. That dome has to be absolutely perfect. I know mine isn't perfect. That's okay. The cornea has to be absolutely perfect in shape. If it's not, as the light rays pass through, they'll be reflected by the shape of the cornea, and they won't go to the part of the eyeball that they're supposed to. These light rays are supposed to come in right in to that spot right there. If the cornea is not shaped right, the light rays will be deflected and they'll end up in a bad part of the eyeball in there, and you won't see right. So when somebody has a cornea that's not shaped right, we call that condition an astigmatism. The cornea is not shaped right. And notice the word, astigmatism. This is not saying that a person has astigmatism. They have an astigmatism. The A is part of the word. They have an astigmatism, right? Because their cornea isn't shaped right. So what we can do is then, when somebody has a misshapen cornea, we can take lasers, or they can take lasers, and go in and literally reshape their cornea to get that dome that they need. And the person might end up with something like this. And then they go, oh, look, still didn't get it right. Okay, let's go and shave this one a little bit more. And they're just using a laser just like I'm using the pen to make that dome perfect. And when you have a perfect dome shape, your vision will be dramatically improved. So that's what a LASIK surgery does. They go in and use a laser to literally just take off micrometers of your cornea to shape it into the perfect dome shape. Now, you can also do that for people who have nearsighted and farsighted. They can do that today now. So that is now a treatment for nearsighted and farsighted, where they can, or a person has a perfect cornea, like, a perfect dome shape on their cornea, but because their eyeball is too long or whatever, their light rays are hitting the wrong spot, and they need to move them to the correct spot. So they'll actually go in and purposely misshape the cornea to accommodate for the shape of the eyeball. And for them, they're actually taking off their dome shape, so that when the light rays hit, instead of going to here, that'll angle them right back to where they should be. So for people with nearsighted and farsighted, they are purposely misshaping their cornea so that it directs the light right where it needs to be. So LASIK surgery is getting pretty advanced today. As a matter of fact, you don't even have to keep your eyes still anymore. Back in the day, when they first started these LASIK surgeries, they had to numb the person's eyeball and actually fix it in a position. And they had an instrument that did that. It actually touched the eyeball and it held it while the laser reshaped the eyeball or the cornea. Today, you don't have to do that anymore. The doctor will have you look into the machine, the doctor looking at the other side will fix a point on the eyeball, program what they want the laser to do, and the laser will only fire when that point is right where it should be. So if you move your eyes like to the right, the laser shuts off that quickly and just sits there. When you move your eye back and that point comes back into place, boom, it starts again. So, you know, it'll take longer time if you're moving your eyes all the time. So they try to tell you, you know, keep your eyes as still as possible, but the laser is not going to damage you if you move your eyeball. And even if you blink your eyes, the laser shuts off that fast, y'all. As you start to blink the eye, the laser shuts off, close, and as the eye comes back open again, the laser turns back on. So this thing is turning on and off in less than the blink of an eye. That's how cool these lasers are getting today. So that's what they're doing when they do LASIK surgery for somebody. They are either reshaping their cornea so that it's perfect, or they're misshaping it so that the light rays get reflected to accommodate for the shape of their eyeball. All right, so that's our sclera and our cornea. I want to clean this up a little bit. What I should do is, in just a second, y'all, let's see if I can find this thing. Heart. It's not in here. EKG, heart. Okay, must be in here then. There we go. So I have to keep drawing this thing over and over again. All right, cool. So y'all don't have to suffer my drawing anymore. Okay, so there you go. So you see up here, this is the sheet that I use in class for labeling. It's also good for drawing if you like to draw or color. And out here is your sclera, the white part of the eye. And the sclera, as it moves around front, it bubbles out into your cornea. And right behind the cornea is a section that we call your anterior chamber. And I'll show you the whole little section in red. The anterior chamber, all of this in here. Right behind the cornea, but before you get into the eyeball itself. That's your anterior chamber. And then back in this part, all of this back here, the vast majority of the eyeball is your posterior chamber. Your anterior and posterior chambers. Anterior in the front, posterior back there. The lens, this structure right here, actually separates the two. Now, those are important to know because they have two different types of fluid in each chamber. And that's why they're separated like that. The anterior chamber has a type of fluid that we call aqueous humor. Aqueous humor. That fluid is constantly created and drained for us. So it's like to keep clear fluid right here, we make new fluid up here, We drain the old fluid down there. So the aqueous fluid is constantly passing through here, keeping that area nice and clean. As opposed to the posterior chamber, which has a type of fluid called vitreous humor. This stuff is never drained. Matter of fact, if you were to drain this, your eyeball would flatten down like a grape, a dried out grape to a raisin. So this fluid is never drained. It's what helps the eyeball keep its shape. So the aqueous humor is constantly being changed through here. The vitreous humor stays. It never changes. And that can cause a condition for us. The aqueous humor being produced up here, being drained down here. Have you ever had a drained faucet at home? You run water into the sink, but the sink is, the drain is plugged or clogged. The sink overflows. So if your area down there, your drain, if that gets plugged up, the fluid will continue to produce up here, but it won't be drained. And that's going to cause your eyeballs to start to swell up. Because you just got too much fluid in there. It's all being created, but it's not being drained. The eyeballs are going to swell up, and that's going to be painful. We call it an increase in inside ocular eyeball pressure. Increased intraocular pressure, or IOP. Increased intraocular IOP. Increased intraocular pressure. Does anybody know what we call that condition when you have increased intraocular pressure? It's in your thing. It's in the slide somewhere. If you have increased IOP, that's what we call glaucoma. And that's why pot works for glaucoma. It doesn't cure the condition. They're still going to have, they're still not going to be able to see well, because not only is this fluid causing this eyeball to swell up, but it's getting all gunked up with crap in there because it's not draining. And as a result, they're not going to be see very well through there. So pot doesn't treat their vision, but it does decrease intraocular pressure. So the pain goes away. So people use pot for glaucoma pain, not to cure the condition. Okay? So it's like a pain reliever for people with glaucoma. Now, y'all, why does pot decrease intraocular pressure? Because pot dehydrates the body. And as a result, it absorbs some of the water in their eyes as well, bringing their intraocular pressure down. So anybody who's using pot should know that you need to be drinking plenty of water with it as well, because pot does dehydrate. So have your water bottles with you constantly. So it absorbs water in the body. There's somebody reaching for something to drink. I see you. Giving yourself away. Don't get me wrong, y'all. If pot was legal, I would be like sitting right here right now. All right, let me tell you about the eyes a little bit. Okay? I am a big proponent for legalization of pot. And I'm not talking about medicinal. I'm talking about recreational. But even if they do medicinal, I've already got my diagnosis of PTSD. All I got to do is go down there and sign up, man. And I'll be the first one in line, too. Where that pot at? Sit out on my front porch and just chill. Anyway, so that's why people with glaucoma do use pot. It does decrease the intraocular pressure, and therefore it takes away the pain of their glaucoma. To treat the condition and get rid of it, you're going to have to open up that drain down there. Just like you unclog a drain, unclog a blocked sink. Got to get in there and clean out that drain. and they use a laser to do that. But it can be pretty expensive. So some people, their insurance won't cover it. So they get the glaucoma. They just smoke pot and listen to the radio. The pot takes the pain away, but they can't see the TV, so they just listen to the radio. So that is glaucoma, increased intraocular pressure. And where does that appear in here? Clouded. There it is. Increased intraocular pressure is glaucoma. Okay, let's go ahead and take our first break. It's 9:25. Let's come back at 20 till. Give us about 17 minutes or so. But still, let's see here. Jordan Carter still in here. Did Jasmine show up? Jasmine Jackson? Still no. Okay. And then Vanessa Pargas and Alma Espinosa. Still no. Okay. Let's take a break. Come back at 20 minutes till. Okay, we're back. Okay, so we've talked about what an astigmatism is. It's a misshapen cornea. So far, you should know that the sclera is the white part of the eye. And then the cornea, the clear part that bubbles out in the front. We've talked about glaucoma and what that is. Okay. So again, this part being your anterior chamber, pointing to right there. Now let's talk about this structure right here. It's hard to tell what that is from a side view like this, but that is your iris. The iris, describe it as the pigmented. Pigment means color. The pigmented part of the eye is your iris. All right, now the iris, again, you're seeing it right there. The pigmented or colored part of the eye, your iris. Now the iris, and there's the test part, the pigmented part of the eye, the iris. All right. Now the iris has some pretty important function that we don't think about or don't know about. Did you know that light rays are attracted to dark colors? If there's a dark color in an area, the light rays will be attracted to that dark color, and less light rays will get to the area around the dark color. So what the iris does for us is that as strong light rays pass through our cornea, some of that is going to be drawn to the iris, and therefore less will actually pass through. So that's what the color of the iris does for us. It absorbs some of the stronger light rays so that less light passes through into our eyeball. And the darker your iris, the more of those light rays it's going to absorb. So people with blue eyes, a light eye color, are almost always going to be grabbing for the sunglasses. Get my sunglasses on. People with darker eyes, dark brown, won't be as uncomfortable out there in the sun because less of the light rays will pass through their eyeball. If you want even less light rays to pass through, what can you do to decrease the amount of light that passes into your eye? There's something you can do, and I'm not talking about putting on sunglasses. There's something you can do that will stop a lot of the light rays from passing into your eyes. Y'all have seen it before. Think about what I've just said. Dark absorbs light. So what can you do? Okay. What if there was an area of dark somewhere near your eyes? Like maybe right here. Y'all know what I'm talking about now? Have you ever seen them do it? The football players, the baseball players, when they put that black
Stuff under their eyes.
that black stuff under their eyes. That's what that's for. That's not war paint. How many of y'all thought that was war paint?
I did.
They're painting up like going to battle type thing. Okay. No, there's a scientific reason for them to do that. And the people on the team that do it should be the person that has the need to look up either into the sun or into the stadium lights, like outfielders on the baseball team, receivers on the football team, the quarterback on the football team. Anybody who has a need to look up for that ball, better put that dark under there. Now it's just become like a sport thing. So anytime you see on TV, they have a football player, it doesn't matter what position they play, supposedly, they're going to put that black on there, okay, because it's part of football or baseball or whatever. But that's the purpose for doing that. As they look up, the light rays get absorbed to their cheek and less of them will pass through their eyes. So that's why they do that. The same thing that our iris does for us, absorbs some of that light so that not as much of it passes through. Now, I know every one of y'all believe that you know somebody whose irises change color, don't you? Everybody knows somebody. Oh yeah, I know this guy, or my cousin, or da da da. I know somebody, their eyes change colors. No, they don't. The eyes don't change color. Now, the exception to that is babies. Babies will almost always be born with a lighter eye color. And as their eyes get exposed to the light, it becomes darker through their, first year or so, first few months. So almost all white babies are born with blue eyes. And then as their eyes get exposed to the light, they mature to what they're going to be. Remember, in the womb, there's no light. The irises don't get a chance to mature until after you're born. So babies' eyes will get darker as they get older. But adults, our eyes don't change color. Okay. And after you're just a few months old, your eyes are not going to change color. So what is it that's happening when I'm not saying that you're not seeing a different color. That's not what I'm saying. I'm saying that their eyes don't change color, but you are seeing a different color. What does that mean? All right. I'm going to pull up something here. It's going to take me a second to find it because I really don't remember where it is. So let me go to here, go into here. I want to go into here. Here we go. Was it 11? Yeah, there we go. All right. Got to move it over. Can I move it over? Oh, man. Why can't I move this? Can I move it over now? No. Doggone it. It's on the other screen, y'all. Okay, let's do it this way then. Can y'all see it now? You see my cursor moving over here? You see all these black squares? Does everybody see that? Give me a nod. You do? Okay. All right. All right. Then I want you to look at this image now, and I want you to count the number of black dots on there. How many black dots do you see? Okay. What happens is that as you look across this slide, the dots move. Why are they moving? Because your eyes are moving. There are no black dots on this slide at all. Is that down there? Black dots? 0. What you're doing is you're experiencing something called carryover. Carryover happens because when we look at an image, I'm looking at this screen over here now. When we look at an image, that image is temporarily stored in our iris, in our retinas. So it's called being burned in. So that image gets burned into your retinas for a few seconds. And if you move your eyes, you may still see that image in your retinas. So, and when you cross across the black, that image gets burned onto your retina. And as you move across here, this spot will appear black. It's called carryover. You see the same thing if you look at a light, like kind of intentionally, the light in the room, just kind of look at it for a couple seconds and then close your eyes. And you can still see the shape of the light in your eyelids. Okay. It's dark and you can still see the light a little bit because it's been burned onto your retina for a couple seconds. So when you are looking at a person who has a light colored eye, hazel, blue, green, if that person is wearing a blue shirt that day, their eyes will appear blue to you that day. You're getting carryover. If they're standing next to a green wall the next time you see them, their eyes will appear green. And then the third time you see them, there's nothing causing carryover in you, and you'll see that their eyes are actually hazel. You go, man, every time I see you, your eye color is different because you're having carryover. It's your eyes doing it to you, not theirs. I used to have a car that was green in the daytime and blue at night. And people would be like, is that car change color? No. It was a trick of the paint. It was more like a teal type color. But when sun shined on it, it looked green. And then at night, with the absence of light passing on it, it looked blue. So it's your eyes that are doing that to you, okay, not theirs. So their eyes don't change color. You're just experiencing carryover. All right. So now I know what to do in that scenario now. I just change the screens. Okay. So anyway, that is the iris. Now the iris has an opening in the middle. This box right there is pointing to it, where the light rays pass through and they hit this thing right there. That opening in the middle is called your pupil. And that's the other test item on that slide, the pupil. I need to do this. Your pupil, the opening in the middle of the iris. Now, when teachers are in class, they want to look out and they want to see all the what? Pupils. That's where that word came from. We want all our students looking at us, and as I'm teaching, I can see your pupils, the opening in the middle of your iris. And that's why we call students pupils. So the pupil is the opening in the middle of the iris. Now your iris has the ability to constrict, looking at it from the side, constrict, close down tight. So less light rays can actually get through there. And most of them get blocked. If you were looking at this from the front, it would look like the iris and the pupil is constricted. It's very small. Constrict, to squeeze. So your pupil is constricted. Now it'll be like this in times of bright light. So if you're outside and the sun is shining, your pupils are going to constrict, have less light in through there. Now this takes a few seconds to happen. So if you step from a dark area into a bright area suddenly, you're going to be getting too much light through and it's going to, ooh, what's wrong? Oh man, it's bright out here. Like when you go from a theater outside during the day. And there's this weird setup over on this one theater up on Ingram and 410. You can go out the door through this side door. When the movie's over, you can just go out through the side door. And the side door opens to a sidewalk, a skinny sidewalk, and then the road where the cars are driving. So you're stepping out of this dark room into bright light, right into a road. Okay? And the bright light is just too bright. Oh. Your pupils are open and you need them to constrict down for you. and block some of that bright light that's coming in. And until that happens, you're going to be uncomfortable. So that's constriction. Pupils are pinpoint or squeezed down tight. Now, at the nighttime, that thing's going to open up wide so that all those light rays can get in there and you can see better at night. From the side, you have your pupil or your iris. And your pupil is wide open, letting all those light rays get through there. That's called dilation. The pupils are wide open. So you can get more light rays at night and you can see better. So at night, you don't want any of these light rays blocked. You want them all to come through. So you can see better at night. It's what we call night vision, being able to see better at night. And actually, we see really well at night, believe it or not. If you have a setup in your bedroom where you have to turn off the wall light and then walk to the bed, you're almost always going to bump into something if it's there. The lights are on, you turn them off, try to walk to the bed. Your pupils are dilated, or excuse me, your pupils are constricted because the light was on. And you're getting less light rays through. You're almost always going to bump into the bed, or you're reaching for the bed post or whatever, trying to get to the bed. But when you get up in the middle of the night to pee, it's no problem. You get up, you walk through, you even find your house shoes sitting on the floor. You walk through, you go to the bathroom, you come back, you don't bump into anything because your pupils are dilated while you sleep and you're pulling in all the light rays. You would also see this is, does anybody live in the country or ever lived in the country outside the city? And buddy, when you go outside at night and you look up at the sky, it looks like TV. I mean, just all these stars. It's like, whoa, look at all the stars out tonight. They're always there. It's not like the stars are out tonight. They're always there. You just don't see them if you live in the city because you got street lights, you got house lights, and all of this. Too many lights. You look up, you see 5 or 6 stars. The rest of them you don't see because your pupils are constricted. Go out to the country where there are no lights out there, and man, you imagine what you wouldn't believe what you can see at night. I've done a lot of exercises outside at night, y'all. Exercises, war games, that type of stuff at night. I've done all that kind of stuff. When I was stationed over at Fort Sam Houston, that was one of our designations. We would send the students out at night to learn land navigation, and we would hunt them out there, kind of like a war game or a war game. And you can see really well at night, believe it or not, if you turn off all the damn lights. And that's one of the rules in the war zone, or in our case, the war games area. No lights, no headlights, no flashlights. Matter of fact, if you turn a light on out there, somebody's going to yell at you. If you light a cigarette, somebody's going to yell at you. No lights out there. It destroys your night vision. So turn off all the lights and we'd be able to see pretty damn well. So the irises are the pigmented part. The pupil is the opening in the middle of the iris. We dilate it to see better at night. We constrict it so that we don't get too much light during the daytime. For your pupils to be in an abnormal position is a sign that you have been drinking alcohol, smoking pot, or doing some other kind of drug, or that your brain is damaged. What do I mean an abnormal state? It's daytime and your pupils are wide open like this. Or it's nighttime and your pupils are constricted like that. And that, by the way, is why the police want you to take your glasses off. Hi, how are you today? Can you take your glasses off, please? They want to see your eyes. They're looking for the state of the pupil in an abnormal state. In other words, if they pull you over at night and they look at your pupils and your pupils are constricted. You've been drinking tonight because your pupils look a little constricted. or they pull you over in the daytime on the highway and your pupils are wide open. You been doing drugs today? Or this right here. Watch my finger. That's the other thing they're looking for. The eyeballs are moving like that. You've been drinking. You've been doing drugs. Or your brain's been damaged. And that's why the paramedic does the same thing. Looking in my eyes, man. The what we are writing when we're checking the eye, when we look in the eyes, the pupil is what we're looking at. Of course, we're looking for damage, you know, blood in the eye or something like that. But to check whether their brain is working right, pupils are equal. Called perla. Pupils are equal, round, reactive, and light accommodative. Perla. And if one of them is not appropriate, we line through it. So this is written on the side of the run sheet, the thing that we're documenting on. So we look at the eyes and their pupils. Are they equal? Are they the same size? Are we looking at something like this? This person's had a stroke. So are their pupils equal? Yes. Boom, they're good. Are they both round, or are we seeing a cat eye kind of thing going on? Yep, both their pupils are round. Are they reactive? In other words, do they move in response to things that pass in front of them? Yes. Are they light accommodative? Do they open and close when I shine the light in there? So that's why we got the pen light going into your eyes. We're literally looking at your irises do this when we pass the light in front of them like that. Light accommodative. So that's what we're documenting when we're looking into your eyes when the paramedic shows up. They're documenting your pupils and are they reactive or not. Now, right behind the pupil is a structure that takes those light rays that are coming through there, collects them, and focuses them down to a fine point. On the back of your eyeball. So it takes the light rays that come in, collect them, gather them, and focus them right down to a fine point back there. That fine point is very important. That's where we see clear, sharp vision right there. And that point has to come right into that spot. If it goes anyplace else, you'll still see, but you won't see sharp, clear vision. For us, it's right there. It's got to be there. The structure that focuses them down like that is called your lens. And you may have done something similar when you were a kid. If you ever got your hands on a magnifying glass or a pair of eyeglasses, and you went outside in the morning when the sun was bright, and you focused that down to a fine point and burned bugs with it. Anybody ever do that? Go out there burning bugs on the sidewalk? Okay, that's exactly what's happening here. And notice that won't start to burn. Did you ever get stupid and put it on the back of your hand? Yeah. Mm-hmm. Ooh, yeah. When it gets down to that fine point, that's concentrating the light down to one point. That's all that light ray and all that heat down to one point. And that's going to burn you. So that's what's happening here. The light rays are being focused down to a fine point right on the structure called your retina. So that's what the lens does. It focuses the light rays down to a fine point like that. And all of this black line right here, This entire black line all the way around is the retina. So remember I said any place the light hits, you'll see. But that has to be right here for you to see clear, fine vision. And yeah, it's a space about that big in relation to this eye. It'd be about that big. If your light rays hit any place else, you're not going to see sharply. All right. Now, let's look at the shape of the eyeball and why, if your eyeball is elongated this way, why is that a problem? Because when your light rays are being focused down, the spot that they're supposed to hit right back here is too far back. And the light rays will actually come to a point before they get there. And what you're going to end up in that spot is a wide view, a wide section of light right there. Remember, it's got to be that fine point. What they're ending up with is a wide section back there. So the light rays are actually pointing right here. The eyeball is too long. If your eyeball is too short, it's elongated this way. When the light rays pass through, they'll never get a chance to come to the point, and you'll have, again, a wide section of light hitting right there. So that's why the shape of the eyeball has to be correct, so that that point happens right where it's supposed to. Otherwise, you're not going to see sharply. All right, so what is that spot right there? Well, let's keep up with the lens for just a second. There's one thing we want to mention about that bad boy, is that we mentioned that if you have the condition of glaucoma, it not only causes increased pressure in here, but it also causes gunk to start to build up in here, since it's not being drained. And that's why people with glaucoma have cloudy vision. Okay. Now, the other thing that could happen to you is that the lens itself start to build up debris on there. And you're going to have a cloudy lens. And that is a cataract. So that's what cataracts are. Cloudiness of the lens. Go ahead and define it like that. It's in your PowerPoint as well. Where is it? Cataract. Cloudiness of the lens. Yeah, it's getting to the point that I can just start playing videos, just start playing these recordings instead of sitting here saying it over. Because you see, it's all the same stuff. I'm not even looking at the PowerPoint, but it's all the same stuff we just talked about. So I'm just going to start playing recording, and I don't have to sit here and talk for 5 hours. Anyway, so the iris is the pigmented part. The pupil is the opening in the middle. Dilation is opening, closing, and what perla is. We've talked about the lens and what a cataract is. So what do we do for cataracts? They shatter them up with, used to be sound waves. They use lasers today as well. Back in the day, they would cut the iris or poke through the iris, or excuse me, the, what the hell is this thing? Sclera, cut through the cornea, go straight back and touch a wand to the iris, which would cause it to vibrate, and it would shatter all this up. Today, they also use lasers. With a laser, they don't have to poke through the cornea. You just shine it right through the cornea and can also break those up. All right, so that's what cataracts are. That's what cataracts are. Okay. One thing that we did mention, and I just thought about it just now when I was talking about cutting through the cornea, If your cornea is misshapen, when we say they can use a laser to try and reshape the cornea, but they can't build up the cornea. So if it's misshapen like this, they might try to curve this out and make a dome shape out of it. But if they feel they can't do that, then they'll just take the whole thing off completely. That whole little light gray section right there. And that's where they cut, right there. Boom, and boom. And just take that bad boy off of there. And then they take the cornea from a cadaver, a dead person, and they stitch it on there all the way around. And those sutures are, let's see if we can find some. What would we call that? Corneal transplant sutures. Look at them bad boys, man. And if you look, you can see just the edge of the cornea right here where they sewed it in place. All the way around. Who the hell put those sutures in there? And now you know why these people make so much money. Guys, I've been sewing for years, decades. There is no way I could put those sutures in there. Remember, this is on somebody's eyeball. And how tiny are those sutures? There's no way I could do that. And that's why they wear those little magnifying things. Have you ever seen those glasses, the ones that have the magnifiers on there? And they are right there just like, boom, sewing them damn sutures on there. So now you know why these people make so much money. There's no way I could do that. So that's a corneal transplant. Taking the cornea off a cadaver and sewing it onto a person because it wasn't the right shape. All right. So let's go ahead now and name this spot right there. The spot on the retina. Now remember that entire black line is the retina. That spot right there is called the macula. Macula. And why does the light have to hit the macula in order for you to see properly? We have two types of eye cells. They are your rods, which we use for black and white vision, and your cones, which we use for color vision. And let's say that the red are for black and white. In the retina, it'd be like this. You'd have all these black and white, all these rods out here. But when you get to the macula, boom. It's all cones. And we need to be able to see colors to have clear, sharp vision. So we have the highest concentrations of cones right there in the macula. That's why our light leads to hit right there. Now, if over years, I mean, you start to get my age, and you see what happens to you. I never wore glasses before. I've only been wearing glasses for about 5 years. I'll be 57 this year, so I started wearing glasses when I was about 51, 52. And I swore I'd never do this, by the way. Never look over the top of the glasses at somebody. I do it all the freaking time now. Sometimes, y'all, I'll be wearing my regular glasses, my just seeing glasses, and I'll be looking at something and I'll forget that I have my regular glasses on. I'll start looking over the top like that. But what the hell am I doing? These are my regular glasses. And yes, I do have 2 pair. I'm supposed to be wearing bifocals and shit, but bifocals would give me a headache. Trying, constant focus between the two. So I have to have 2 pair of freaking glasses, man. So anyway, and I've only been doing this for about 5 years. What's happening to me? Over time, the macula is breaking down. And it's called macular degeneration. The macula is burning down, macular degeneration. And it's the most common cause of age-related decrease in vision. Everybody's going to suffer this as they get older. And that's in your slides. So let's find it so you can actually see it. Intraocular pressure, nearsighted, farsighted, macular degeneration. The most common cause of age-related decrease in vision, macular degeneration. And there are your eye cells, rods and cones. Know which one is which. Cones see color. Get that? Cones see color. See? That play on the C. And rods for black and white. And the most common cause of age-related decrease in vision is macular degeneration. And there is nothing we can do about it. Eyeglasses. LASIK surgery won't work. Nothing. Eyeglasses, period. Maybe they can do an eye transplant, I guess, but eyeglasses. So that's why I would, yeah.
Can you get an eye transplant?
Yeah. Yeah, they do eye transplants. Now, I don't know, not all the time, but yeah, they do.
Prosthetic eye.
Huh?
My son has a prosthetic eye.
He does?
Yeah.
It would depend. They have to look and see, like, is he like Stevie Wonder
Yeah.
or Ray Charles?
Right. Ray Charles.
Well, Stevie Wonder, because Stevie Wonder was born without optic nerves. So he can't have an eye transplant.
No.
But Ray Charles had everything was intact. The eyeballs were damaged.
Well,
The
see, my
eyeballs
son,
fell.
he got shot with a paintball gun.
Uh-huh.
And it like shattered his whole eye.
His eyeball?
Yeah.
Yeah. Then if it's the eyeball, yeah, you can transplant the eyeball. But so Ray Charles could have had eye transplants. Stevie Wonder, that wouldn't have worked because it wasn't his eyeballs. It was the nerves that go back to his brain. Those were not there. So transplanting the eyeball wouldn't have worked for him. And by the way, they've both been offered eyes from people, and Ray Charles and Stevie Wonder both turned them down. You know, people out there who were dying, and you know, a big Ray Charles fan. Some guy got cancer. His eyes were okay, so he said, "I want to donate my eyes to Ray Charles," and they both turned him down because they were saying, you know, I've been blind this long. You know, to be suddenly be vision might just be too much of a shock. I'm used to living my life like this now. And Ray Charles actually said, "What if my wife is ugly?" He actually said that. What if I find out my wife's ugly? You know. So anyway, it all depends on whether the damage is to the eyeball or to the nerve tract. And the Stevie Wonder is the nerve tract. All right, so have those in your notes. Cones for color vision, rods for black and white. The most common age-related decrease in vision is macular degeneration. And let's go on and mention this term while we're here as well, presbyopia. Presby means old. Y'all ever heard of this church, the Presbyterians? That's the old church. They believe in the Old Testament. Some religions don't. They believe that the Old Testament is a bunch of metaphors. But these people really believe that Jonah lived in the belly of a whale and that kind of stuff. So they believe in the old church or the Old Testament. Presbyterian, the old church. So presby means old, and opia is vision. So presbyopia is the age-related decrease in vision. The most common cause of that is macular degeneration. The macula is breaking down. So that's what presbyopia is. Presby, old. Decrease in vision. All right. Let's see what we've missed so far. Iris, pupil, cataracts, intraocular pressures, glaucoma, anterior and posterior chambers and their fluids. Wait a minute, this is not right. Oh, okay, I see what that is. All right. And then nearsighted and farsighted. You know, got to get that down. Nearsighted is called myopia, and farsighted is hyperopia. You know those designations. The medical term for nearsighted, myopia. And there's the shapes of the eyeballs. If it's too long, you're going to be nearsighted. If the eyeball is squished down too short, we call that farsighted. In those terms, myopia and hyperopia. Yeah, all these pictures are small. Is anybody old enough to remember these things? The very first projection TVs.
Yeah.
This bad boy would project light from here up onto a mirror that would reflect up onto the screen from these three bulbs down here. So project right onto this mirror and then up onto that screen. These things were horrible, y'all. Matter of fact, I used to laugh at anybody who bought one of these things back in those days. I mean, the picture was, you could barely see the thing. You had to be like right in front. If you moved anywhere to the side, you couldn't see it. So these things were ridiculous. However, take a look at, why did I bring this up? Red, blue, green. With the combination of those three, you can make any color. Any color. Not even, you can't think of anything. Those three colors can be used to make any color. And that's why the TV was fashioned like that, with those three colors. It was fashioned after our own eyeballs. We have rods for red, blue, and green. Red, blue, and green. Now, some people, that's spelled reb, some people will actually not have some of these. And they might be what?
Colorblind.
Colorblind. Hey, they might be red colorblind.
My cousin's colorblind.
And usually the blue and green typically go together. The most common state of colorblindness is blue-green colorblind. And that's going to happen more commonly in men.
Mr. Mahal,
Mm-hmm.
my cousin is colorblind.
Uh-huh.
And I always tell him to pass me the red controller.
So he's red colorblind.
No, he's just colorblind in general. He just sees black and white.
Really?
Yeah.
Oh, okay. All right.
And it's weird because he's in the military.
Oh, really? Okay. Well, the thing is,
And he's a mechanic.
I was just going to say that he's not going to fly airplanes.
No.
No, that's impossible. You can't. They won't allow that if you're blue-green colorblind or any of the colorblinds. You can't fly airplanes with eyeglasses either,
Hey.
or contacts, or any type of corrected vision. You have to have 20/20 uncorrected vision in order to fly an airplane. And that's one of the reasons that the guys in the military would sometimes try and cheat on their, and not just fly, but work aboard airplanes. So people would cheat on their eye exams and stuff so that they wouldn't lose their flight status. 20/20 uncorrected vision. So those are our color vision cells, red, blue, and green. Now we talked about the retina, so this is what I want you to know about that, is that the retina, if you think about it like my arm, this being the eyeball, the retina covers the entire back of the eyeball, and then all those nerve fibers come together into one nerve that transmits back to your brain. The retina picks up light rays and transmits them to the brain. Picks up light rays and transmits them to the brain. I'll go with y'all slow writing again. In the classroom right now, I'd be making fun of y'all. Because same thing in the classroom, I turn around like, geez, y'all, come on, man. Y'all pencil still going? Y'all write slow. Better learn some shorthand. I'm going to call yourself want to be a doctor. Y'all better learn some shorthand, man. All right, so anyway, here you see the retina coming around in black. All those nerve fibers come together into one big nerve fiber that transmits the signal back to your brain. Now, if you were really just kind of trying to get this to look the way it actually does, you do something like this. The nerve would come up, turn, and then the nerve fibers would be sticking down into that layer like this. Anything that gets stimulated right there by light gets passed along this nerve fiber down into this big bundle that takes it back to your brain. Okay. So if this retina, for some reason, gets pulled away from the inner wall of the eyeball, like that, the nerve fibers coming in there will not be picking up anything from the retina. And in that part right there, they won't be able to see anything. Now, our retina, the entire thing, covering the entire back of our eyeball like that, it picks up light rays from different directions. Like that. And down here, it'd be picking up light rays from this direction, like this. Now, the lens is going to take the most intense rays, the ones coming from the front, And those are the ones that get focused down to the macula. The rest of them will still stimulate the retina. So in your peripheral vision, you might know something's over there, but you can't focus on it because your focus is this direction. Your lens is this direction. So if you want to see what's over there in detail, you have to turn your head and look. So we get light rays from all directions, and all that's being detected and sent to my brain. But only the ones right in front of me are going to be clear and sharp for me. The rest will be just stuff out there. Okay. So if the retina becomes detached like that, I won't be able to see anything coming up from the floor. And that's a retinal detachment. Usually happens with blows to the head. So we see it in boxers and football players and stuff all the time. They get a retinal detachment. Now they use a laser to fix it back up into place. But those nerve connections are going to take a while to start to actually be stimulated again. So even after they reattach everything, it'll be about a month before they're really able to see from that spot again. They've had a retinal detachment. Remember, the retina picking up light rays from all directions. So light rays coming in from my right side are going to be picked up by the left side of my eyeball, picking up light rays from the other direction. So that's what a retinal detachment is. Now, all those nerve fibers come together from everywhere, the macula included, and all of that gets into one bundle, taken back to your brain. And if you remember the brain, we process vision in the occipital lobe at the very back here. And that's important as well because if you look at the top of a person's head with their two eyeballs side by side, well, actually, let me move those down a little bit. Let's do it this way, the long way. Okay. Top of a person's head with their eyeballs side by side, and they're looking in this direction. The optic nerve comes off the back of each eyeball, headed to the back part of their brain. But at first they need to cross each other like that. And then to the occipital lobe of their brain. Why is that crossing so important? Our eyes pick up light rays, and you've seen, I've done this already, like this. They actually overlap each other. And if the optic chiasm, this part right here, you know what? Let me check that. That's one of those words I have to check every time. Let me just use this. IASM. Okay. IA. Too many eyes. Because it's not spelled how it's pronounced. It's pronounced chasm. Okay? The optic chiasm, this area right there where the crossing happens, takes all of this and puts it together as one picture. What you're seeing is 1, 1, 2, 2. You got two eyeballs, but look what you're seeing right here, 1 and 2. So if the optic chiasm didn't take all of this and put it together as one full picture for you, you'd be seeing double vision in the center all the time. So if there were 3 students sitting in front of me, I'd see this student, I'd see that student, but the student in the middle, I'd be seeing her twice, or that student twice. The optic chasm deletes that and puts it all together as one picture for you. So if you're having double vision right in the center, you may have a tumor in here that's pressing on your optic chasm, and you're seeing double vision in the center. So that putting it all together for us is called stereo, since there are 2 of them, stereoscopic vision. And because we can see in more than one dimension, 3-dimensional. Dimension, height, width, and depth, 3 different dimensions. Since we can see depth, we are 3-dimensional viewers. We have 3D stereoscopic vision, and the optic chasm is responsible for that. That's a test question. The part of vision that's responsible for 3D stereoscopic vision, the optic chasm. And that's also in the PowerPoint. Let's find it. I know it's there. There it is. The optic chasm, 3D stereoscopic vision. And the last one we already have, hordeola, medical term for sty. This one we got up on the first line. Okay, so let's talk about this for just a minute, and then we'll move on and get the ears done. We'll finish a little bit early today. Okay, what is this? What the hell does that mean? Everybody say it all the time. I'm 20/20. What does it mean? Anybody? Come on, what does 20/20 mean?
Perfect vision.
Okay, did somebody say perfect?
Yes.
Okay, that's the word I wanted to hear. Okay. There's no such thing as perfect vision.
Right.
We tend, now 20/20 is the average vision of everybody. They took a bunch of people that they knew had no vision trouble, and they used those people as the standard for everybody else. In other words, what this is saying is that, first of all, the first number will always be 20 because you stand 20 feet away from the chart. So you put your chart on the wall, you take a measuring tape, you measure out 20 feet, you put a piece of tape on the floor, and that's where the person stands. So 20 feet from the chart. And you're seeing what average people see when they stand 20 feet away. And that's based on vision tests done on thousands of people who they know have no vision issues. Okay. When they stand 20 feet away, they see this. When you stand 20 feet away, you see the same thing. You are 20/20. You have average vision, the same as everybody else. What if that second number gets smaller? 20/15. What are you saying about this person? They're standing 20 feet away from the chart, but they're seeing what you would see if you were only 15 feet away. So they took those same thousands of people, had them stand 15 feet away from the chart, and they were able to see better or more of the chart. So these people are actually seeing better than 20/20. And I've measured some people who were 20/15. So they're seeing better. The smaller the number, the better you're seeing. The chart actually goes down to 2010. I've never seen anybody read the 2010 line. But 2010 would be that you are seeing as if you're only 10 feet away from that chart. You're 20 feet away, but you're seeing as well as somebody who's only 10 feet away. You're seeing much better. So the smaller the number, the better the vision. And on the opposite side, the larger the number, the worse they're seeing. Imagine somebody who is 20, 40. They're only 20 feet away from that chart, but they might as well be, they're 20 feet away. They might as well be 40 feet away because that's how they're seeing. So they're standing here, but they're seeing what somebody sees when they stand back here. So it's like they're further away from the chart. They can't see. Their vision is worse. So the bigger the number, the worse your vision. The number up at the, or letter up at the very top of the chart, that big E up there, that's 2200. You're standing right here, but you're seeing like somebody who's way the hell down here off the board. You can't see any of that shit. You might as well be 200 feet away is what they're saying. And all you can read is that E. You're 2200. That's legally blind. You can start looking for a disability based on that. Okay. So that is your eye assessment, 20 feet away. The chart that we use is called a Snellen chart, and they come in the, you know, the letter chart, the E, C, F, G, U, F, R, O, K, getting progressively smaller. Okay. And then we have the E chart. This is one where it also gets progressively smaller, but it only has on there E's facing different directions like that. And you tell as they do it, they would say right, up, left, down, for somebody who doesn't read English. And then there's the shape charts with the, you know, the sailboat and the ball and the star, I can't make stars, but there you go. So anyway, that's for pediatrics, children who can't read. They also refer to it as the pediatric chart. So y'all like my sailboat? Isn't that cool? That's the first time I've ever done that. All right, so anyway, I'm proud of myself. So that is your Snellen chart. I know it doesn't take much to excite me anymore. I'm an old man. All right, so anyway, that's your Snellen chart and assessing a person's vision. Now, a couple of rules about that, guys, is number one, don't let them cover their face with their own hand. Because, you know, if you put your hand up there right now, you know, you can see right in that crack between these two fingers. You can look right through there. We give them a little blind to put up over, a little piece of plastic that covers the eye completely. You're going to do the test 3 times. First, you're going to do their right eye, which is ocular dexter, 20, 20. Left eye, ocular sinister. You remember that? The left eye is the evil eye. Ocular sinister, 2015. Ocular universal, both eyes, 2015. That's how you record their eye exam. Goes to the doctor like that. Ocular Dexter, like Dexter's Laboratory. Ocular Sinister, like evil, and Ocular Universal. Right eye, left eye, both eyes. And it's reported to the doctor like that. So anytime you do an eye washing on somebody, the first thing you're going to do afterwards is an eye exam. That's why we did these so much in the emergency room. Somebody come in, something in their eye, we irrigate their eyes out, Okay, doc, Mahone, let's go and get a Snellen or eye exam and have them go on and do that to see if what we did or what happened to them affected their vision at all. I'm still writing. Jeez. All right. So that is your basic eye exam and what we're doing there. All right. So let's review this real quick. Left row is eyelid. A hordeolum is a medical term for sty. The lacrimal apparatus produces and drains tears. A strabismus is abnormal deviation of one eye. The sclera is the white part of the eye. The iris is the pigmented part, and the pupil is the opening in the middle of the iris. The cataract is cloudiness of the lens. Increased intraocular pressure is glaucoma. Nearsighted is called myopia. Farsighted is hyperopia. Cones are responsible for color vision. Rods are responsible for black and white vision. And the most common age-related decrease in vision is macular degeneration. The retina picks up light rays and transmits them to the brain. The optic chiasm, responsible for 3D stereoscopic vision. It's again the medical term for sty. And we'll do the ears when we come back. So let's take another break. It is about 10 till, let's take a break till 5 minutes after 11, and we'll get the ear done. It should take us about another hour. All right, let's get the ears done. And folks will be coming to clinics more about ear trouble than eye trouble. Most people with eye issues are going to go straight to their optometrist or ophthalmologist. But people with ear troubles are going to be walking to your clinics all the time. Okay. The specialist that works in this area is the otorhinolaryngologist. Y'all know of that as the ear, nose, and throat doctor. Oto is ear. Where's my pen? Oto is ear. Rhino is nose. And laryngo is throat. The ear, nose, and throat doctor. Okay, and I wanted to get this term in here right away. Oto is ear. Rhino means drainage or flowing. That is, as in what term? Diarrhea. Okay. Otorrhea is drainage coming from the ear. And that's usually not a good sign. That's one of the first signs that you have a skull fracture, is fluid leaking from your ears. And we talked about that when we did the brain and nervous system. Okay. Drainage flowing from the ear. Oh, man. See, that's my ADD kicking in, y'all. I just realized there's something else in the brain that we didn't look at, which I usually do. But anyway, otorrhea, drainage from the ear. The purpose of the ears is twofold. Number one, they give a sense of hearing. We know that. We hear with our brain, but we pick up the sound waves with our ears. And they also give us the sense of balance. There is a tiny area in our ear that acts like a bubble level or carpenter's level. If you've ever seen that little stick with the little glass tube in the middle, got the little fluid in there and the air bubble, let you know when the bubble is between the two lines. We've got those in our ears. They don't look like that, but they function the same way. Let us know when we are off balance. So we get our sense of balance, which many people try to refer to as our, I think I mentioned it before, our sixth sense is a sense of balance. And that comes from the ears. The structures of the ear, I use the same picture that's in your textbook down here. And we'll talk on here. All of it's in the slides up there, and we'll look at those when we need to. Okay. We'll start out here with this part that hangs on the side of your head. Doesn't do a whole lot for us anymore. It's called your pinna, two ends. Your pinna. Another name for it is auricle. The pinna or auricle, the thing that hangs on the side of your head. We use that to hold our glasses in place. We use it for decoration, but we don't use it as much to hear anymore. The reason is that if you'll notice in most people, the pinna is back against the head almost. Now, you might know a few people out there who are still like this. I mean, y'all know somebody whose ears stick straight out like this. Okay. Now, would you believe that they actually hear better than you?
Yeah.
They pick up sound waves better than you do?
Yes.
If you were to, and I don't know where your speakers are, so it probably won't work for you like this, but in the classroom, I would have the students hold their pinna forward like this as I talk, and they would hear a distinct change in my voice. They're hearing it better, and I'm hearing it right now because it's reflecting back off of, or it's echoing back off the TV screen, the actual screen itself. So as I pull my ears forward, my voice changes, and you actually pick up more of those sound waves that are directly in front of you. Now, other animals who can still direct this thing, you'll notice that when they hear sound, they turn this thing towards it, and they pick up the sound better. And as I'm doing this, my voice, I'm hearing a different change, a change in my voice as I'm talking. because I'm picking up more or less depending on which direction I turn this thing. But since most people can't move it anymore, in order to hear it better, you're actually going to have to turn your ear towards it, and you will hear that sound a little bit better. However, when we hear a sound, what's the first thing we do? Let's imagine I hear a sound coming from over that way.
Turn towards the sound.
What's the first thing I'm going to do? I'm going to do this,
Turn
right?
towards the sound.
And you see what I just did? I turned my ear away from it and turned my eyes towards it. So our ability to see better through evolution has actually done a disservice to our ears or to our hearing. So because the first time we hear something, the first thing we do is turn our head towards it and turn our ear away from it. You'll notice that blind people don't do that. The sound is made, they turn their ear towards it so that they can hear it better. Okay, so it doesn't do a whole lot for us since we can't move it anymore. Eventually, it's going to go away. See, it's already moved back against our head like this. Eventually, all of this will be connected, and it will really be back against your head like that. And go another 5,000 years in the future, it may just be a hole right there with some bumps around it. So this thing is going to go away since we don't use it. Remember that rule? You don't use it, you lose it. Now, once it goes away, what are we going to do with our eyeglasses? I wonder. Everybody's going to have the geek strap. Y'all know the one that goes around back and you always made fun of the kid in school who had one. The nerd strap, whatever you want to call it. I have one. I use it when I do my hobbies and stuff because my glasses always sliding down my nose when I'm doing stuff. I just don't wear it in public. I'm not about to. And you know what else I'm not going to do? The chain. Not happening. Sorry. I'm not doing the chain. I told my wife 100. I'm not doing it. You need to get. I ain't doing no damn chain. All right, forget that mess. Not even for sunglasses because it looks kind of, I don't know, I call it California-ish to wear the sunglasses hanging on the little thing. So what do I do instead? Check this out, y'all. My glasses fold up. Put them in my pocket. I ain't wearing no damn glasses hanging around my neck. You forget that mess. Anyway. So that's how I carry two pair of glasses. I carry these in my pocket. All right. So the pinup doesn't do a whole lot for us, but keep it clean because you tend to build up debris, old earwax and that type of stuff all in the little crevices. Get in there and clean that out. Otherwise, you can't nibble on ears. Hey. You ever nibble on somebody's ear and get a little bit of crust off of there? Y'all don't be acting like looking at me like y'all ain't know what I'm talking about. Y'all know good and well. Y'all done been necking and all that stuff in the basement. Oh, y'all don't have basements. That's a damn shame. You know, the basement is the world, y'all. That's the kids' world right there. Everything happened in the basement. You got your first kiss. You got your first clothes burning. Yeah, all that happened in the basement. So not having basements, y'all lose out big time. But anyway, keep this thing clean. And how do you keep it clean? Well, you might use Q-tip or something like that. But don't ever, pay attention to me now, don't ever stick anything in your ear. Not even a Q-tip. Have y'all ever read the instructions on the Q-tips? No, y'all haven't, because y'all think y'all know everything. Read the instructions, and it says right there on the package, do not insert in the ear. Yeah, Don't be sticking stuff in your ears. You know, even we don't do that. Paramedics didn't even do that. If we saw something in the ear, we tried to wash it out with fluid. If we couldn't get it out with fluid, call the doctor. Then the doctor would come down and stick an instrument in the ear and pull it out. Even paramedics couldn't do that. So don't go sticking things in your ear. So you can imagine what happens with me when my wife, Mm-hmm. Takes the bobby pin or the toothpick and scratch it inside the ear. Is that a girl thing? Scratching inside y'all damn ears. Somebody's laughing. Somebody's shaking their head. Maybe it's a black woman thing. Yeah. You know what else is a black woman thing? Crooked fingers. Yeah. I make fun of my wife's fingers all the time. And one day we were in class and I was talking about, how I make one of my wife's fingers. And one of my students, black lady, go, look, Mr. Mahal. Oh, damn. And then another student in the same class, look, Mr. Mahal. Oh, I figured it might be a black woman thing, crooked fingers like that. But anyway, don't go sticking things in your ears, man. Bobby pins and toothpicks and scratching the ear. And it just makes me cringe every time she does. I'm like, babe, stop that. My ear itch. Leave me alone. Damn, girl. So anyway, you're going to poke your damn ear out one day. Makes me think of the guy who died trimming his nasal hair. How the hell did that happen? He was using a pair of iris scissors. Y'all call them cuticle scissors. The pointed little silver ones. And he's in the bathroom mirror. And somebody opened the door. Boom. Hit him right in the elbow, right up his nose. Large artery up there, right through that artery, and he died. It happened in the dormitory, trimming his nasal hair. Somebody opened the door, poof, right up his nose. So every time she's like scratching her ear, I always think, girl, anything could happen, man. But anyway, so don't go sticking stuff in your ears. Now that's your outer ear, the pinna. Now the outer ear canal right here is lined with a specialized membrane that produces mucus. And that's a specialized mucus. It's not the same stuff that your nose produces, the membrane in our sinuses. This produces a sticky kind of mucus. We call it earwax, or the medical term for earwax. That's a test question. Cerumen is how it's pronounced. Cerumen, the medical term for earwax. Now, some people will produce too much cerumen, and as a result, they might end up with a big glob of wax in there that actually blocks their ear canal. And the sound waves coming through there will be muffled if they get through it all. And you might be hearing like woo, 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 instead of conversation or words, in which case we got to get that earwax out of there. And the way we do that is we wash it out with fluid. And medical assistants will learn how to do ear washes. Not as important for PCTs, but in clinical environment with children, you'll be doing quite a few of these. You learn how to prepare the liquid, what technique you use. We use large syringes, and you just and catch it in the basin on the side of their head. Fill up, and keep doing that until this thing washes out of there. And you will, again, learn that technique when you do your clinical classes. Okay, so anyway, that is cerumen in there and doing an ear wash. You don't have to ever do ear washes unless you have a problem with wax. I keep telling my wife, like, she needs to get the wax out, man, because, she can't hear me. I'm not saying she can't hear me. She can hear just fine. But I don't know, the vibrations from my voice, the I don't know, decibels or whatever, she just can't hear me. She can hear every damn thing else. Remember what she does? All the damn time. I've been doing that to her lately too, y'all. And she's been getting mad at me because she'll say, babe, I go, huh? Like, you heard me, huh? So I've been getting her back, and there's like, I don't know what, 4 times yesterday. I'm not talking to you no more. So anyway, I told her she got to give me $1 every time she's not talking to me. So she owed me $4. I'm not talking to you no more. Yeah, punk. Huh? So she needs to get the wax out, man. She can't hear me. Anyway, so that is cerumen, the medical term for earwax. Now, when we do an ear wash, we can also soften the wax before we do it. We can put a little drops of medication in there called Cerumen X or Debrox. They both soften earwax and help us to wash that out a little bit better. All right, so that is cerumen and ear washes. You may also find yourself, especially if you work in acute care, pediatrics, or emergency room, you may find yourself occasionally having to go in there and get them cockroaches out. Anybody's ears itching right now? Y'all see me keep doing that. Yes, cockroaches, I said it, because they tend to crawl in people's ears while you sleep. Yeah. And you get them out the same way you wash them out. Yeah. So don't be surprised. Matter of fact, you'd be surprised how many bugs you swallow in your lifetime. One day I was teaching a class over at Fort Sam, and we taught, well, when we was traveling around, so I don't know what base we're at or what state, but we were teaching outside. And a bug landed on my face while I was teaching. And I don't know what made me do this. I just grabbed the bug and kept talking. And all the students were like, oh my God. Oh, that's just horrible. And that's why I did it, for the shock value. I couldn't believe I did that. Afterwards, y'all, I'm over behind the truck going, I don't believe I did that shit. Washing down with water, picking bug legs out my teeth and shit. But you just do it for the shock value. They expect that from us back then. Teaching classes outside, you're supposed to be the tough macho dude. I just ate the freaking bug. So anyway, you'd be surprised how many bugs you get into your respiratory tract, digestive tract, into your ears and things like that in your life. All right, so anyway, that is your external ear or outer ear. Right there. All of this. The external ear. More commonly referred to as the outer ear. And the cerumen. Now, as the pinna does help to direct sound waves into the ear, passing along the outer ear until they reach this structure right here. Called your eardrum, or the medical term is tympanic, since tympano means ear. That structure right there is your tympanic membrane. The medical term for eardrum. And I think that's a test question. Tympanic membrane, the medical term for eardrum. And it is a thin membrane stretched across an opening like the bladder on a drum. And as the sound waves interact with it, it moves back and forth, just like hitting a drum. So the sound waves hit the thing, boom, 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 and it moves back and forth. All right. Now that's your tympanic membrane or eardrum. Now that motion or vibrations of the tympanic membrane, that causes this, again, membrane to vibrate. And that vibration gets transferred to this bone right here. This is a tiny bone, the smallest bone we have in our body. And its name is the malleus. The malleus converts that vibration to the next bone right here. And that bone is called your incus. The incus then transfers the vibration to a third bone right here. Called your stapes. Stapes. The malleus, the incus, and the stapes, the bones of the middle ear. See that area in yellow coming down? Is your middle ear. The bones in the middle ear are the malleus, the incus, and the stapes. So as the tympanic membrane vibrates, it pushes on that bone, causing it to vibrate, which transfers to the next bone, which transfers to the third bone, carrying the sound vibrations. Now, they're not sound waves anymore, they're vibrations. And it carries those vibrations across the middle ear through those three bones. Now, I think the test question about the bones is they're known collectively. All three of those bones together are your auditory ossicles. That's an I right there. Your auditory ossicles, the bones in the middle ear. And they're essential to get that vibration across the middle ear. You see, sound waves will travel through space or air, but vibrations don't. So once the tympanic membrane starts to vibrate or converts those sound waves into vibrations, they have to be carried across this space. Otherwise, they would not get there. They wouldn't get across. Now, the space, why is it there in the first place, is very important that we have that space. The bones are just there to carry the vibrations across. But the space is there for a reason. And that is, you might see it or you might not, this little tube right here, coming down like that, connecting your middle ear to your throat. And that's why the doctor works on all three of these areas, the ear, nose, and throat. They're all connected. The ears are connected to the throat. You know, the nose is obviously connected to the throat. We looked at the digestive system. But the ears are connected to the throat through this tube right here. The tube is called, I don't know if you can see the name real well down there, so I'll write it. The eustachian tube. The word means, EU means normal or good. And statio is pressure. So what eustachian means is good pressure. Eustachian tube, good pressure. Its job is to equalize the pressure on both sides of the tympanic membrane. Meaning that if the pressure out here goes up, it's going to push your tympanic membrane backwards. This is the outer ear, this is the inner ear. The tympanic membrane should be shaped like this or curved like that. If you get too much pressure out here, it pushes it backwards. And does anybody know what sound vibrations you're going to get coming in if your eardrum is pushed backwards like that? You can't vibrate. They're going to be numbed or dulled. So what you need to do is get pressure on this side to be the same as the pressure on that side and push it back out normal again. Good pressure. So how do you get this up here to increase the pressure in here to push it back for you? I'm not tired. That's how you do it. You yawn. When you yawn, it sends a gentle push of pressure up this way into the middle ear, pushing your tympanic membrane back like that. You can also do it by swallowing. You swallow saliva and you get the same thing, a little push of pressure up there, and that pushes it back for you. Now, this is going to happen whenever you change pressure outside. For example, you go up in an airplane and they start pressurizing the cabin. The truth is, guys, they're not really pressurizing the airplane. That's not the purpose they're doing it. The pressure is the byproduct of pumping oxygen into the airplane. As they're pushing air in, the pressure in there is going to get greater. So the airplane doesn't need to be pressurized. They need to pump oxygen in there for everybody to breathe. That increased pressure pushes everybody's tympanic membrane backwards. And then you swallow to move it back. Now, some of y'all may have heard that you hold your nose and blow. How many of y'all have heard that before? When your ears pop, hold your nose and blow. It'll work, but what you're getting is this. When you swallow, you get a gentle push. But when you hold your nose and blow, you get. So that's not what you want. You don't want to do that. Just swallow. And that's how you knew who the pilots in the Air Force were. They chewed gum all the time. Why do they chew gum? To produce saliva so that they can swallow and clear their ears when they're flying. So the pilots always had these really well-developed masseter muscles, the chewing muscles. So their jaw was like, sculpted, like George of the Jungle type sculpting in the jaw because they chewed gum all the time to clear their ears when they fly. All right, so that's the eustachian tube and what it's there for. However, it not only brings pressure up from the throat, but it also brings bacteria. And we mentioned how much bacteria is in the human mouth. Yeah, a lot of bacteria can move up this tube into your middle ear, causing the otitis media. Otitis is infection of the ear. Otitis media, infection of the middle ear. Test question. Infection of the middle ear, otitis media. You can also have otitis externa, the outer, and otitis interna, the inner. But the most common ear infection is otitis media because the middle ear is connected to the throat and all that bacteria gets up into the throat. It's going to be more common in children. One of the reasons is that in children, the eustachian tube doesn't dip down like that. Actually, it comes more almost parallel. So the bacteria from their throat moves more easily along the tube. By the time you're an adult, the eustachian tube is dipped down like this. In babies, there it is right there. So the bacteria from their throat gets easier into their ear. All right, so what do we do with somebody who gets otitis media? We're going to treat them with antibiotics. But what if they're getting it repeatedly? Because they're babies, the baby that's just always tugging at their ears. They've always got an ear infection. The doctor may consider tympano, meaning ear, tympano tubes. They're going to tube the baby's ears. Oh yeah, this is going to tube their ears. Tympano tubes are really easy to put in. They are self-cutting, if you will. You load it on an instrument, a tube like that. The instrument, you slide it forward and you put it to the tympanic membrane, and the instrument is allowed or designed to give it a little twist. As soon as you twist it, boom, it goes right through the tympanic membrane. And you have something like this. Their tympanic membrane, like it should be, bowed out with the tube sticking through it. So now any pus that builds up in here, what's pus, by the way? White cells showing up there to destroy the bacteria. That's why pus is white. So any pus that builds up back here can drain out, and it won't put pressure against their eardrums and make their ears hurt. So the tympano tubes don't keep you from getting an ear infection. They keep the ear infection from hurting while we treat you with the antibiotics to destroy all that bacteria back there.
So, sir, like buildup of like mucus or wax or whatever, it's not like causing some of the ear infection? Because I used to hear that when I was little all the time. You got too much like wax buildup or something like that. That's what the ear. Not at all.
We need to wash the wax out if you got too much in there, but it's not what causes ear infections in people. No. Tympano tubes. There you go, in place. Looks like that. This silvery gray area back there, that is the tympanic membrane or the eardrum. And that's the way it should look. And that's why the doctor wants to look into your ears. If the tympanic membrane is red or pink, you have an ear infection. It should be silvery gray in color. So you see this tube sticking right through, you can actually see through this tube, into their inner ear. Anything that builds up back there will drain out this tube. There were some pretty nasty ones in here last time too, tubes that have been left in too long. Some tubes will come out on their own. Some have to be removed by the doctor. It depends on the type of tube they use. That thing's been in there way too long. And what does this one look like? Yeah, left a big old hole in there. These are holes in the tympanic membrane. But they had some pretty nasty looking tubes on here last time I came on here to look at this. What is that right there? Yeah, that's been in there too long. See the infection happening around it. Yeah, it's just been in there too long. And these are people with holes in their eardrums. My wife has a hole in her eardrum. It's kind of cute, little bitty hole. You know, oh look, he got a little hole in there. Ain't that cute? But anyway, these are infected ears. Look at that mess. All that. So anyway, tearing holes in the eardrum. Look at that. That almost makes you want to gag. Just how nasty these infections can get in people's ears. All right, so that's your tympanic membrane and why we're putting those tubes in the baby's ears. Once the baby has a second ear infection, the doctor should consider tympano tubes. Doesn't mean they will, but they should at least consider. There's no reason for this baby to go through continuous pain like this when we could just put tubes in their ears. We'll keep fighting the infections, but you know, at least they won't be in pain. One of the most common or a common cause of ear infections in babies is, come on mamas, what causes ear infections?
Water?
That milk getting in there.
Baby bottles.
Liquid.
Laying down in
Milk
their
drips
Laying down
there.
and eating, drinking their milk while they're laying down.
Yep.
Another common cause is no smoking around the babies. Period. If you have to go outside to smoke, put on a smoking jacket. Put something on your head to cover your hair. And when you come back in, wash your hands and face before handling the baby. Take your smoking jacket off, hang it up, take your hat off, hang it up, go wash your hands and face, and now you can handle the baby. The chemicals in your clothes, the chemicals in your hair, the chemicals on your hands and face. The baby can still inhale those. And those move up into the middle ear and cause the infections. So no smoking around the babies.
Okay, what about that old school whole thing where they used to blow smoke in the ear, or was some kind of remedy, a home remedy?
Oh, yeah, I've heard of it before, but I don't know why they
They
would do
blowed it on the top of the
it.
baby's head for colic.
Yeah, yeah, something like that. Yeah,
In the ear too.
yeah, there was
My
some.
grandma would my grandma would do newspaper and light it on fire by the ear.
Uh-huh. That was designed to melt the earwax. You know, for somebody who gets earwax built up out here. Remember, it's just wax. It'll melt just like a wax candle. So if you can get heat flowing up into here, they'll melt the wax and it'll run out. That's why ear candles work, if y'all have ever heard of those. You actually put them into the ear like a little cone, and then you light this part. The hot air gets directed into the ear and it melts the wax in there.
Like the peroxide stuff, when they pour peroxide down your ear, it's eating up the wax too then.
Now that's what we do in healthcare. The stuff we wash the ear out, which we use peroxide in there. We don't use ear candles in healthcare because of the open flame, but they do work. But they'll use them at spas and places like that. We don't like open flame in healthcare, but they do work just as well. But we're going to wash out instead, and we mix the fluid with peroxide. And by the way, ear washes is the only thing I've ever done in my career that made me nauseous. Guys, I had a patient throw up in my mouth once while doing CPR. I've had some horribly nasty things happen, but the only thing that ever made me sick was doing ear washes on people. And I think it's the combination of the peroxide and the earwax and the odor and and that plug coming out and plopping down into the basin, this black gray plug that just got out. And it always made me nauseous. So, and that's the only thing that I've ever done. Guys, I used to debride this guy's mouth in the morning. He had cancer of the palate, cancer of the roof of his mouth. And I used to have to go in and debride his mouth every morning. You want to talk about bad breath? Pulling dead tissue out the roof of somebody's mouth every morning. And that didn't bother me. But doing ear washes literally made me sick to my stomach. And some years ago when I was teaching over at Quest, one of the teachers came in and asked me if I'd wash the ears out. And I thought, you know, it's been a while. Okay, let me try it. It's been some years since I did it. So I went on and did it. And yeah, I got nauseous doing it. So I don't know what it is about doing it that makes me nauseous, but ear washes. So anyway, that is your middle ear with the tympanic membrane, the eustachian tube, allowing us to equalize pressure on both sides. If you've never been out of Texas, get out of Texas, y'all. Just go out there and see the rest of the world. You drive through Missouri, and Missouri has hills. So I know they talk about the Texas, the foothills and all. Texas ain't got no damn hills, or the hill country. Texas ain't got no damn hills. Texas is almost flat as Kansas. But when you go through Missouri, you're going through some hills, man. Up, down, driving your car up, down. Your ears are actually popping as you go up and down on the freaking road, going up and down these hills. I don't think there's any place in Texas that could cause that to happen. Texas is flat, man. If it wasn't for the curve of the planet, you could probably stand in Louisiana and see New Mexico, man. Texas is so damn flat. So anyway, and y'all don't have trees either. These things y'all call trees. Give me a break. In Missouri, you can't even put your arm around the freaking trees, man. They're so freaking big. All right, so anyway, that is your middle ear with your eustachian tube. Now, where are those vibrations going? When the sound waves come in, they hit the tympanic membrane, they started to vibrating. Those vibrations are transmitted through these three bones, the auditory ossicles, into what looks like a snail right there. That structure is the actual organ of hearing. It's called your, pronounced cochlea. And that's a test question. Cochlea, the organ of hearing, your cochlea. It's the curled up part. The upper part is something different. We'll talk about this part here in a little bit. But that part right down here, this curled up part, that's your cochlea. And if you look closely to the diagram, you'll see that there's a nerve right here attached to the cochlea that carries that up to your brain for you. So that's the route. Sound vibrations or sound waves enter the outer ear. They strike the tympanic membrane, started to vibrating. That vibration gets transferred through three bones into fluid of the cochlea. The vibrating fluid stimulates the nerves, and that gets sent to your brain. And that's hearing. If you could take the cochlea and roll it out straight, flat, it would look something like this, with the bone attached right there, fluid in here, and the fibers from that nerve coming in and sticking down like that. Carrying that up to the brain. So these nerve fibers, they're for different frequencies. Sound is really weird, hard to understand, that things vibrate at different frequencies. So these vibrations coming in here are all coming in at different frequencies. And these nerve fibers are picking up just that one frequency. Now we also have another section right down here that brings sound waves up our eustachian tube and stimulates that part. Not real important, but this one up here is called the oval window, and that one down there is your round window. R-O-U-N-D, your round window. So you're getting vibrations from two different directions. So what you're doing is you hear your voice in quadraphonics. So when you speak, it comes into both ears, but it also comes up both your eustachian tubes, and you hear it 4 ways. You hear everybody else's voice twice. And that's why your voice doesn't sound to you the way it does to everybody else. When I speak to somebody, they hear my voice in stereo, but I hear my own voice in quadraphonics. I not only hear it through my ears, but I also hear it through my eustachian tube. And that's why some people, have you ever heard a recording of yourself speaking? Doesn't sound like you, because you're only hearing that recording in stereo. You're used to hearing your own voice in quadraphonics, and your voice will sometimes sound a little bit deeper than it does in the recording. Yeah. So when people are singing and they don't sound real good, cut them a little bit of slack, because they don't sound the way themselves. They don't sound the way they do to you, because they're hearing it in quadraphonics. It's kind of like singing in the bathroom as opposed to singing outside. Almost everybody can sing in the shower. So that is both. Now, each one of those being a different frequency, nerve fibers. Sound is so weird that our frequencies and vibrations are so weird that, you know, the reason that the buildings fell down in New York City when the airplanes hit them? Because they were vibrating.
They had bombs.
What? What'd you say, Chris?
Bombs.
Bombs?
Yeah.
You know, a lot of people think that.
And
here's why. The building like this, and as the floors started to collapse, they were seeing little, what looked like explosions down below the collapse as the building was coming down. They're like, look at that, boom, and then it gets down, boom, but so it was before the building was actually falling. They were seeing little explosions down here. You go, look, those are bombs. No, they weren't. If you put some powder on your hand right here, and then you do like that, what's going to happen to the powder? So as those floors were collapsing, they were pushing things out. The same way you get like this.
That's logical.
So as each one of these floors came down, the compression below caused this to blow out right there. Came down further, as it fell even further, the compression caused that to blow out. So you saw all these little blowout explosions happening, and people saying, look, those are bombs. No, that was the compression of the floors falling inside the building. Okay. Now, what caused those buildings to fall was that when the airplane hit them, they started vibrating. And that vibration got carried all the way down to the foundation. And eventually it was vibrating so violently that everything just collapsed. When you think about people in the past, guys, don't think that our ancestors were stupid. It's going to sound, that sounds a little bit off topic, doesn't it? But think about this. Joshua and the Battle of Jericho. How many know your Bible? You might just know the song. Joshua and the Battle of Jericho, and the walls came a-tumbling down. Y'all remember that? What did they do? They marched around the city for 100 days, blowing horns. Boom, 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 boom. Thousands of soldiers. Boom, 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 boom. They're marching all in unison like that. What did it cause? Vibrations. And the walls came tumbling down. They vibrated until they fell. That could have happened for real. Because physics will tell you right now today, if you stand at the base of the tallest building in the world with a hammer in your hand, and you hit that building repeatedly in the same rhythm for days, bang, 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 bang. Eventually that'll get incorporated into the entire building. And those vibrations could make the building fall down with a hammer. So they could have actually made the walls fall down just by marching around and causing the vibrations. So vibrations happen at different frequencies. And each one of these nerve endings detects a different frequency. And what would happen if you damage one of these bad boys? You'll never hear that frequency again. But remember, you've got hundreds of thousands of these in your ears. Doesn't mean you don't hear anymore. You just won't hear that frequency. And that's what I mean when I say my wife just can't hear my voice. She can still hear all the other frequencies. She just can't hear me. So how do you damage these nerve fibers? Okay. How many of y'all have ever heard a gun go off? I mean, a real gun. Not on TV, but there with you. Boom! That's just loud, ain't it?
Yep.
All right. Okay. Now, I like shoot 'em up movies, like Arnold Schwarzenegger and Sylvester Stallone and John Wick just go in and shoot shit and blow shit up. Okay. I like that kind of stuff. All right. So now, here is Arnold Schwarzenegger in a movie called Commando. They kidnap his daughter, and he's the big, black ops soldier dude. They kidnap his daughter. So he goes to get her back, and they're on this island, and he goes onto that island and he kills everybody. Hey, boom, 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 bang, 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 explosions going off and shooting the big guns and the big machine guns and all of that. Boom, just killed everybody. Got his daughter back. So now he's walking to the airplane. The soldiers are showing up now, get dudes on his side after he killed everybody. They showing up. So he's walking to the boat, the daughter on his shoulder. And the guy comes running up. The colonel comes up. He says, hey, did you save anything for us? And he said, just bodies. And the music comes up and he goes off with his daughter. Okay, now, here's how that would have played out in real life. Did you save anything for us? Huh? Did you say, huh? What? What'd you say? You can't hear a damn thing. Rambo, Schwarzenegger, they'd all be deaf today. John Wick, they wouldn't be able to hear shit. Going through all that, no hearing protection, nothing, all them damn explosions and gunshots going off, nobody be able to hear a damn thing. They'd be sitting up in the nursing home like, huh? What'd you say? Like my wife, huh? Anyway, so that is how you damage your damn ears. If you've seen a movie called Black Hawk Down, anybody seen that one? Now, that's a true story based on what the people who were there told them. That's why the movie is so realistic and why you saw so many what looked like mistakes, because that kind of shit happens. When the guy who was standing under the helicopter and they were shooting, ta, 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 and the rounds were falling down in his shirt, he's like, oh, shit. That's the kind of stuff that happens. You don't see that in movies, though. In the one scene, there are two guys together. One's shooting this way, the other one's shooting that way. When he gets done over here, he turns around and starts shooting in the same direction as his buddy. However, his buddy's head was right there. And they went through, that guy went through the rest of the movie like this. Huh? Yeah, he's got that big gun. I can't hear nothing. That was true. That was that guy they interviewed him. He said, yeah, during that, most of that, he couldn't hear anything because his partner fired the gun right next to his head. That's how you can torture somebody without killing them. Tie them in a chair, take a gun, put it right next to their ear, and pull the freaking trigger. You know how much that's going to hurt? So that's how we damage our hearing. We work in on the flight line. Y'all know, y'all hear the big airplanes go over here. On the flight line, when the engine's running, but there's no thrust being applied to the engine, it makes a high-pitched whining sound. That's what destroys your hearing. That's why they wear those headphones down there. If you work in a cabinet making place with all the saws going all the time, you're not gonna be able to hear shit. If you are a DJ, I can't hear on my right ear. I mean, I can hear, but not near as well out of my right ear anymore. I wore my headset on this side. And the head music coming through the headset has to be louder than what's in the club. So I really don't hear very well out this ear. And that's good for me. Why is that good? That's the side my wife sits on when I drive. And she's just talking about her day and work, and I'm if you hear me, you know I can't hear because I can't hear out this ear. And she tells people today, she's like, she's pulling up right now too. She tells people, I gotta tell her, she tells people right now that she made me quit DJing because I couldn't hear. That's not why. We was at the club in Greece, and when they want you to play their song, want you to play their request, they come up and they write it on the little chalkboard we had right there. But then they come down front and they flash you. Hey, and I go, I got you, right? So she was sitting up there one day, and these girls wanted me to play the song. So all three of them lined up in front. They did like this, right? So she leans forward, like, you quitting this damn job. She didn't want me to see the boobs anymore. So, yeah. But she tell people, I made him quit because he can't hear. No, you made me quit because I could see them boobs. Anyway, so one day I took my son out to the gun range, and we were shooting. And there was a dude, a couple stalls down from us. And, man, this dude had one of those 50 caliber handguns. It wasn't a Desert Eagle. It was this big revolver thing, the one that only fits like 4 rounds because the rounds are so freaking big. And my son was like, Daddy, look at that gun. I said, well, check it out. Gun people like to talk about guns. So he walked over, the guy talked to him for a few minutes, and he's like, well, I'm going to shoot now. And so Timothy's standing there like this with his his noise suppressors around his ear, around his neck, like. And the dude's like, oh, Timothy turned around like, yeah. I told you don't take those damn things off. You never take those off at the range. So anyway, I bet he damaged the frequency that day. Okay. So anyway, that is what happens when you are damaging frequencies in there. You can't hear that frequency anymore. And as we get older and we can't hear as well, remember the word for old? Presby, and in this case, presbycusis. Decrease in hearing as you get older. Remember, presbyopia was vision. This is hearing. You don't hear as well as you get older. Presbycusis. All right. So that is the nerve carrying those frequencies back to our brain. Our brain sorts them out for us, searches our memory, and lets me know if I've ever heard that thing before. And this is so complicated, guys, that you can actually hear your wife talking and the TV going in the background and the dog barking in the backyard, and you can discern the difference between all of those, hearing them all at the same time. So it's a pretty complicated system, allowing us to hear. Now I want to go back here and talk for just one more second about hearing, and that is that our tympanic membrane is so thin and sensitive that if those sound waves stimulate it too violently, it will continue to vibrate for sometimes hours. So after you leave the club, all the loud music in there, you might be home for an hour and still your tympanic membrane is still vibrating. And it's going to make a little sound when it does. Boo. Your ears are ringing. And that's called tinnitus. You got tinnitus, ringing of the ears. And there's that slide right there, tinnitus. Buzzing, hissing, ringing, or roaring sound in the ears. Tinnitus. So it can sound like a bee. It can also sound like a woof, 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 a roaring sound in your ears. That's your tympanic membrane that's vibrating and it won't stop. Now, there are other things other than loud sounds that can cause tinnitus, and you see them right there. And since I take aspirin every day, I have constant tinnitus. My ears ring all the time. So what do you do to sleep at night? Put some ambient noise in the room, a fan or something like that. Something to drown out the tinnitus. Otherwise, you'll be laying there all night just listening to your ears ring. And that's another reason that my wife and I don't often sleep in the same bed. The fan bothers her, but without it, in a quiet room, I'll lay there listening to my tinnitus all night long. So that's tinnitus, buzzing, hissing, ringing, or roaring sound in the ears.
Mr. Mahone.
Yes.
I notice that happens to me a lot, but after I drink caffeine, like coffee or anything that I drink, like it has a lot of caffeine.
Uh-huh.
That happens to me a lot. And I start freaking out, like, what's going on with me?
Yeah. Yeah. You're having caffeine withdrawal. Yeah. 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 You start to feel it. And my wife gets it sometimes. I won't say it, but yeah, she gets caffeine withdrawal because she drinks all this coffee and stuff all the time. So it's a little bit of a headache happening because you are low on caffeine. All right, so that is tinnitus, the ringing in the ears. Again, try a fan or something like that. There's supposed to be drops that can help to minimize the tinnitus, but since I take aspirin all the time, the drops don't work for me. So I just put something in the room so it's not like completely quiet all the time. All right, now let's talk about this part right here. This upper part. The lower part was for hearing. The upper part is for balance. These are those bubbles the bubble levels I was talking about. Let me erase that. And there are actually 3 of them. One right here. One right here. And the third one is right here. And it's hard to see what they actually do because it's hard to draw them the way they actually are. The upper tube, like this, is actually angled from left to right. The next tube angled like this is actually angled from front to back. And then the third one lays flat like this and gives you rotation. So one tube lets you know when you're leaning left or right. The other one lets you know when you're leaning front or back. And the third one lets you know when you're spinning. All three of them are known as your semi-circular canals, responsible for our balance. All right, and those are those bubble levels we talked about. If we went inside one and looked at it, you would see the tube filled with fluid. And the nerve fibers come in like this. And when you rotate your head, remember the fluid level will stay level, but the tube will rotate. And as the tube rotates, the stones in this fluid come in contact with that nerve fiber and let you know you're turning your head that way or the other way or whatever. Okay. So that is your semicircular canals, helping to maintain your balance. Now think about this one. The one is angled flat lets you know when you're spinning around. Now it's fluid in there. So if you spin around and get that fluid to moving, it lets your brain know that you're going around in circles. What happens if you stop all of a sudden? The fluid continues to move and makes you feel, dizzy. That's why spinning around and stopping, you're going to feel dizzy because the fluid continues to move in there. And every time that fluid moves to the left, you're going to adjust to the right. And it swings around to the right, you're going to adjust to the left. And you see it really obviously in that stupid game where you put your head on the baseball bat and run around the baseball bat 3 times and then try to run to first base. And they run like that. Left, right, trying to get to front base, get to first base. Now, you don't even have to drink the beer. And that's what they do. Drink a beer and then head down. You don't even need the beer. One idiot, this idiot, rather than putting the baseball bat down and putting your head on there and then going around the baseball bat, he was standing with the baseball bat on his head and just spinning around. That's how, just that freaking drunk. Couldn't even figure out what to do right there. So anyway, that is your semicircular canals, helping you to maintain your balance. Now, there is a type of infection that happens in the semicircular canals called Meniere's disease. It's autoimmune, and it causes inflammation inside those little tubes. If that happens, you're not going to be able to stand up. The good news is that it comes and goes, and you might say the Meniere's was acting up that day. Yeah, you're not going to get out of bed today. You're not going to stand up today. Matter of fact, you're going to be like that person who's been drunk and the bed is spinning. And you'll be like that until they get you treated. And like y'all don't know what I'm talking about, do you? Y'all ain't never been drunk, have you? Yeah, get home and throwing up, swearing you're never gonna drink again, and laying down on the bed and trying to put a foot on the floor because that doesn't help. No, that doesn't help, y'all. Putting a foot on the floor doesn't help. It's just your cerebellum back there is being affected. So Meniere's disease, they get that sensation of constant spinning, leaning left, leaning right, spinning all at the same time. That Meniere's disease. All right. So let's make sure we've talked about everything for the ears. We've done cerumen, the medical term for earwax. What's this one up here? Otorrhea, drainage from the ear. The tympanic membrane is the eardrum. Otitis media is the middle ear infection. And bones of the middle ear are called the auditory ossicles. The cochlea is the organ of hearing. Know it as the part of the brain that transmits sound waves to, or a part of the ear that transmits sound waves to the brain, your cochlea. And again, the semicircular canals, responsible for your sense of balance by sending information to the brain about the position of your head. Is it left, right, forward, back? Is it spinning? And then finally, tinnitus, the buzzing, hissing, ringing, or roaring sound in the ears. All right, so we didn't make any changes to the PowerPoint. It's all there. You'll see all the reds there. And right now, what I'm going to do is, I don't need to save anything because it's all the same. Close that. Close that down. I want to close that and close that. And then I'll go back to here and close that. Anything in here I need to pay attention to right now? Nope. My order has shipped. I said that already. Okay. Okay, Jaime, I'll look at that a little bit later. Now I want to go here. And when is Tuesday? Tuesday's the 8th. No, Tuesday's the 11th. And I want to make this in the morning. All right, and we'll leave it like that, the 11th. All right, so that is your eyes and ears quizzes. It's active until Monday night. So you might want to go ahead and get that cardiology done, maybe tonight or tomorrow night or whatever. And then go on and get this one done before Monday night. We have 2 more next week over the respiratory and urinary systems together, and then the skin and reproductive systems together. And we'll be covering all those next week. So that's your quiz is. I'm going to click send before I forget, because I have done that before. And I activate it until Monday night over the eyes and ears.
Sir, so after we're done with your class, that's like in like 2 weeks now, right?
Next week is last week.
Okay, so are we having to go into the school again, or they'll contact us?
Well, is this your first module or second module with me?
My first.
Okay, you got one more module with me.
Okay.
You'll be with me a total of 6 weeks. So next week will be the 3rd week, and then you have 3 more weeks. So you don't have to worry about that until the end of the next module. Those folks that are having their 2nd week with me, Sarah, Chris, Isaac, Tatiana, Cassie, Elena, they'll be all Maria, they'll be all moving on to their next module at the end of next week. Class ends on Thursday next week, so we have a 3-day weekend coming up as well. All right. So any other questions? Okay, it's 12:15. Now would be a good time to get some of that homework done. We got 3 people already done. Yeah, Chris.
Which tests are due?
The heart and blood this weekend due by Sunday.
Okay, let me do that.
And then the eyes and ears due by Monday.
And then the digestive one's still on there, right?
Yeah, I reactivated. Get in there and get it done if you haven't.
Okay, thank you.
Any other questions? All right, I'm going to go on and close the meeting now. I will see y'all on Monday. Have a good weekend. Get that heart and blood done. On Monday, we're going to be covering the respiratory system. We'll be talking about asthma and all that good stuff that people have questions about. All right, we'll see y'all on Monday.
See you, sir.